Welcome to Musculoskeletal, Skin, and Connective Tissue Audiobook for USMLE Step 1. Let's start with Anatomy and Physiology of Bone, Muscle, Connective Tissue, and Skin. Now listen carefully. Upper extremity nerves can be injured in several ways, and each nerve has its own classic causes and presentations. First, the axillary nerve, which comes from C5 to C6, can be injured by a fractured surgical neck of the humerus, or by an anterior dislocation of the humerus. This results in a flattened deltoid, a loss of arm abduction at the shoulder, especially beyond 15 degrees, and a loss of sensation over the deltoid and lateral arm. Now let's talk about the musculocutaneous nerve, arising from C5 to C7. It is usually affected by upper trunk compression, and this can diminish the biceps reflex, particularly from the C5 to C6 roots. The patient will have a loss of forearm flexion and supination, and a loss of sensation over the radial and dorsal forearm. Next, the radial nerve, from C5 all the way down to T1, can get compressed in the axilla, like from using crutches or sleeping with the arm draped over a chair, something we call Saturday night palsy. It may also be injured in a midshaft fracture of the humerus, or with repetitive pronation and supination, like when using a screwdriver, leading to what's described as finger drop. Injuries above the elbow can cause loss of sensation over the posterior arm and forearm, and also the dorsal hand, with wrist drop, meaning a loss of elbow, wrist, and finger extension, and reduced grip strength because wrist extension is essential for full flexor action. You should remember this. Injuries below the elbow may instead cause paresthesias of the dorsal hand, due to the superficial radial nerve, or result in wrist drop from injury to the posterior interosseous nerve. If you have a midshaft humerus fracture, the triceps function and posterior arm sensation are typically spared. Now moving on to the median nerve, which also comes from C5 to T1. A supracondylar fracture of the humerus causes a proximal lesion of the nerve, while carpal tunnel syndrome and wrist laceration are distal lesions. These injuries can lead to the classic ape hand and hand of benediction. There's also loss of wrist flexion, and dysfunction of the lateral two lumbricals, opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. Those are your loaf muscles. With a proximal lesion, you also lose sensation over the thenar eminence, and the dorsal and palmar aspects of the lateral 3.5 fingers. Now let's turn to the ulnar nerve, from C8 to T1, which can be injured by a fracture of the medial epicondyle of the humerus, representing a proximal lesion, or a fractured hook of hamate, a distal lesion, often from falling on an outstretched hand. Compression can also happen as the wrist rests on a handlebar during cycling. You'll see an ulnar claw on digit extension, and radial deviation of the wrist during flexion if the lesion is proximal. There's also reduced flexion of the ulnar fingers, impaired abduction and adduction of fingers due to interossei weakness, poor thumb adduction, and dysfunction of the ulnar two lumbricals. Now listen carefully. This injury also leads to loss of sensation over the ulnar 1.5 fingers, including the hypothenar eminence. And there's more. Injury to the recurrent branch of the median nerve, also from C5 to T1, usually from a superficial laceration of the palm, causes the ape hand. This results in loss of the thenar muscle group functions, including opposition, abduction, and flexion of the thumb. But unlike the median nerve injury more proximally, this one does not cause any sensory loss, which is an important distinction. Finally, remember this useful mnemonic: humerus fractures, when we trace them from proximal to distal, follow the arm nerves, axillary, then radial, then median. So, say it again to yourself: axillary first, then radial, then median. That's how injuries line up along the humerus. Now listen carefully. The shoulder muscles that form the rotator cuff are essential for stabilizing the glenohumeral joint, and each one has a unique function and innervation. The supraspinatus, which is innervated by the suprascapular nerve, initiates abduction of the arm, specifically before the deltoid takes over. It's the most common site of rotator cuff injury, whether from trauma, degeneration, or impingement, often leading to tendinopathy or even a tear, and this condition is typically assessed using the empty can or full can test. Are you following me? Next is the infraspinatus, also supplied by the suprascapular nerve, and its main role is to externally rotate the arm. This muscle is commonly injured in throwing athletes, particularly those involved in repetitive pitching, and its weakness or pain may lead to compromised shoulder function. Then, we have the teres minor, innervated by the axillary nerve, which assists in both adduction and external rotation of the arm, contributing to shoulder stability especially during rotational movements. Now let's talk about the subscapularis, which is innervated by both the upper and lower subscapular nerves. Unlike the others, this muscle internally rotates and also adducts the arm, playing a significant role in medial shoulder strength. All these muscles, supraspinatus, infraspinatus, teres minor, and subscapularis, are primarily innervated by spinal nerves C5 and C6. Together, they form the rotator cuff, which you can easily remember using the acronym SITS, with a small t for teres minor. You should remember this: the supraspinatus lies just beneath the acromion, and attaches near the greater tubercle of the humerus, while the infraspinatus and teres minor also insert around the greater tubercle. The subscapularis, on the other hand, attaches to the lesser tubercle. Anatomically, these insertions are crucial for coordinated shoulder movement and integrity, and when one is damaged, the whole system can suffer. Now listen carefully: arm abduction is a coordinated movement involving different muscles and nerves at different degrees. From 0 to 15 degrees, the supraspinatus is the primary mover, and it is innervated by the suprascapular nerve. From 15 to 90 degrees, the deltoid takes over, and it is supplied by the axillary nerve. But to raise the arm above 90 degrees, you need help from both the trapezius and the serratus anterior. The trapezius, which elevates and rotates the scapula, is innervated by the accessory nerve, while the serratus anterior holds the scapula against the thoracic wall and allows upward rotation, and it is innervated by the long thoracic nerve. Now listen carefully: the brachial plexus lesions begin from roots C5, C6, C7, C8, and T1, and involve nerves such as the long thoracic, radial, and axillary. These roots form trunks, upper, middle, and lower, which then divide into anterior and posterior divisions. These divisions give rise to cords, lateral, posterior, and medial. From these cords come the terminal branches, musculocutaneous, median, and ulnar for flexors, and radial and axillary for extensors. Conditions related to these lesions include herb palsy, also known as waiter's tip, clump palsy, wrist drop, winged scapula, deltoid paralysis, Saturday night palsy, decreased thumb function, difficulty flexing elbow, variable sensory loss, hand of benediction, and dysfunction of intrinsic muscles of hand, causing claw hand. Now let's talk about specific conditions and how they arise. First, herb palsy, also called waiter's tip, results from traction or tear of the upper trunk, specifically C5 to C6 roots. In infants, this can happen due to lateral traction on the neck during delivery, and in adults, it may follow trauma that leads to neck traction, such as falling on the head and shoulder in a motorcycle accident. The affected muscles include the deltoid and supraspinatus, which impairs abduction, causing the arm to hang by the side. Also affected are the infraspinatus and supraspinatus, leading to medial rotation, and the biceps brachii, resulting in loss of flexion and supination, producing the classic waiter's tip posture. You should remember this with the phrase, "Herb gets DIBs on tips." Are you following me? Let's continue with clump palsy, which involves traction or tear of the lower trunk, specifically C8 to T1 roots. In infants, it's caused by upward force on the arm during delivery, and in adults, it often results from trauma like grabbing a tree branch to break a fall. The affected muscles are the intrinsic hand muscles, including lumbricals, interossei, thenar, and hypothenar. The functional deficit is a claw hand, and remember this as clump palsy, because the lumbricals normally flex MCP joints and extend dip and PIP joints, and their dysfunction leads to the claw-like appearance of the hand. Now let's talk about thoracic outlet syndrome, which results from compression of the lower trunk and subclavian vessels, most commonly within the scalene triangle. The causes include cervical or anomalous first ribs, or a Pancoast tumor. The muscle deficits are the same as in clump palsy, involving the intrinsic hand muscles. The functional deficits include atrophy of intrinsic hand muscles, along with ischemia, pain, and edema due to vascular compression. Now listen carefully. Another classic lesion is winged scapula, which arises from lesion of the long thoracic nerve, affecting roots C5 to C7, which you can recall as the wings of heaven. Common causes include axillary node dissection after mastectomy, or stab wounds. The affected muscle is the serratus anterior, and the functional deficit is the inability to anchor the scapula to the thoracic cage, which means the patient cannot abduct the arm above the horizontal position. The scapula protrudes like a wing, especially when pushing against resistance. Finally, are you ready for a key anatomical reminder? The divisions of the brachial plexus follow the mnemonic, remember, to drink cold beer. Also, the trunks of the brachial plexus and the subclavian artery pass between the anterior and middle scalene muscles, forming the scalene triangle. But the subclavian vein passes anteromedial to the scalene triangle, not through it. Now listen carefully. The bones of the wrist region include the scaphoid, lunate, triquetrum, and pisiform on the proximal row, and on the distal row, you'll find the hamate, capitate, trapezoid, and trapezium. To remember their order, use the mnemonic, so long to pinky, here comes the thumb. The scaphoid, which is palpable in the anatomic snuff box, is the most commonly fractured carpal bone. This typically occurs due to a fall on an outstretched hand, and you should be aware that proximal scaphoid fractures carry complications like avascular necrosis and nonunion, because of the retrograde blood supply coming from a branch of the radial artery. Keep in mind, this fracture is often occult and may not be visible on initial X-rays. Now let's talk about the lunate, another key carpal bone, because its dislocation may impinge the median nerve, which can lead to carpal tunnel syndrome. Similarly, if the hook of the hamate is fractured, this can cause ulnar nerve compression, resulting in Guyan canal syndrome, a condition that involves motor and sensory symptoms on the ulnar side of the hand. All of these carpal structures are important, and the diagram includes bones such as the capitate, hamate, triquetrum, pisiform, lunate, scaphoid, trapezium, and trapezoid, along with the radius, ulna, and the first metacarpal. The anatomical orientation is shown along the palmar surface, marked with the flexor retinaculum, which is also called the transverse carpal ligament. Are you following me? Now let's explore what lies inside the carpal tunnel, and here's where it gets clinically important. The tunnel contains the median nerve, flexor digitorum superficialis tendons, flexor digitorum profundus tendons, and the flexor pollicis longus tendon. Outside the tunnel but close to it, you'll find the ulnar nerve and ulnar artery within the Guyan canal, and also the flexor carpi radialis tendon. The plane of section clearly reveals the structures that pass through or near the carpal tunnel, and damage or compression in this region can affect grip strength, finger movement, and sensation. Now let's talk about the hand muscles, which are organized into distinct groups. The thenar eminence, innervated by the median nerve, includes the opponens pollicis, abductor pollicis brevis, and the flexor pollicis brevis, which has both superficial and deep heads, the deep head being innervated by the ulnar nerve. Also part of the hand is the adductor pollicis, which is supplied by the ulnar nerve. On the other side, we have the hypothenar eminence, supplied by the ulnar nerve, and it includes the opponens digiti minimi, abductor digiti minimi, and flexor digiti minimi brevis. These muscles are crucial for pinky finger movements. Now listen carefully to the interossei muscles. The dorsal interossei, innervated by the ulnar nerve, are responsible for abducting the fingers, and the palmar interossei, also by the ulnar nerve, are in charge of adducting the fingers. This is easily remembered with the mnemonics. DAB stands for dorsals abduct, and PAD stands for palmars adduct. Next are the lumbrical muscles, where the first and second are innervated by the median nerve, and the third and fourth are by the ulnar nerve. These muscles flex the MCP joints, and extend the PIP and dip joints, playing a vital role in coordinated finger movements. Finally, are you ready for a helpful summary? Both the thenar and hypothenar muscle groups perform the same set of actions. They oppose, abduct, and flex, which you can remember with the mnemonic OAF. Now listen carefully. At rest, a balance exists between the extrinsic flexors and extensors of the hand, and also the intrinsic muscles, particularly the lumbrical muscles, which are responsible for flexion at the MCP joints, and extension at the dip and PIP joints. When this balance is disrupted, particularly due to nerve injury, we see what's called clawing, which is best observed in distal lesions of the median or ulnar nerves. In this setting, the remaining extrinsic flexors of the digits exaggerate the loss of the lumbricals, causing the fingers to extend at the MCP, and flex at the dip and PIP joints, resulting in the classic claw posture. Now let's talk about the presentation. In proximal lesions, the deficits are less pronounced and usually manifest during voluntary flexion of the digits, rather than at rest. For clinical signs, remember this: the ulnar claw appears during finger extension or at rest, and is caused by a distal ulnar nerve lesion. The hand of benediction is seen when making a fist and results from a proximal median nerve lesion. Meanwhile, the median claw appears during extension or at rest, and is due to a distal median nerve lesion. Lastly, trouble making a fist is the sign associated with a proximal ulnar nerve lesion. You should remember this: atrophy of the thenar eminence indicates median nerve lesions, while atrophy of the hypothenar eminence is a sign of ulnar nerve lesions. These visual cues can guide your neurological diagnosis in patients presenting with hand dysfunction. Now let's shift focus to the knee exam. Are you ready? First, remember the ligaments. From the lateral femoral condyle to the anterior tibia, we have the anterior cruciate ligament, or ACL, and from the medial femoral condyle to the posterior tibia, we have the posterior cruciate ligament, or PCL. To recall the direction, just remember the mnemonic LAMP, lateral to anterior, and medial to posterior. Now listen carefully to the test procedures. The anterior drawer sign is positive in an ACL tear, where the tibia glides anteriorly relative to the femur when the knee is bent at a 90-degree angle. Alternatively, you can perform the Lockman test, where the knee is placed at a 30-degree angle, which is often more sensitive for ACL injuries. The posterior drawer sign is used to diagnose a PCL injury, and it involves bending the knee at 90 degrees and observing posterior gliding of the tibia. Now let's talk about the valgus stress test, which is abnormal passive abduction. It involves applying a lateral, valgus, force with the knee extended or at approximately a 30-degree angle. If there is medial space widening of the tibia, that suggests a medial collateral ligament, or MCL injury. In contrast, the varus stress test, abnormal passive adduction, knee extended or at 30 degrees angle, this test applies a medial, varus, force, and lateral space widening of the tibia indicates an LCL injury. Finally, let's review the McMurray test, which is used to evaluate meniscal tears. During flexion and extension of the knee, combined with rotation of the tibia or foot, remember the mnemonic line. Pain or popping on internal rotation with a varus force suggests a lateral meniscal tear, because internal rotation stresses the lateral meniscus. Pain or popping on external rotation with a valgus force indicates a medial meniscal tear, because external rotation stresses the medial meniscus. Now listen carefully. Let's begin with the actions of the hip muscles. For abduction, the primary muscles involved are the gluteus medius and gluteus minimus, which help move the leg away from the midline of the body. For adduction, the key players are the adductor magnus, adductor longus, and adductor brevis, drawing the leg back toward the center. When it comes to extension of the hip, the gluteus maximus, semitendinosus, semimembranosus, and the long head of the biceps femoris are responsible. On the other hand, flexion of the hip involves the iliopsoas, which includes both the iliacus and psoas, along with the rectus femoris, tensor fasciae lata, pectineus, and sartorius muscles. Now let's talk about the rotational movements of the hip. Internal rotation is carried out by the gluteus medius, gluteus minimus, and the tensor fasciae latae. Meanwhile, external rotation is powered by the iliopsoas, gluteus maximus, piriformis, obturator internus, and obturator externus. Each of these muscles contributes to the fine control and full range of motion at the hip joint, which is essential for activities like walking, running, or even just standing with stability. Now let's shift focus to the lower extremity nerves, starting with the iliohypogastric nerve, which comes from T12 to L1. It provides sensory innervation to the suprapubic region, and motor innervation to the transversus abdominis and internal oblique. A common cause of injury is abdominal surgery, especially inguinal hernia repair, and it can lead to neuropathic pain, described as burning or tingling, at the surgical site, radiating to the inguinal and suprapubic region. Next, we have the genitofemoral nerve, arising from L1 and L2. It provides sensory input to the scrotum or labia majora, and medial thigh, and motor control to the cremaster muscle. It is often injured during laparoscopic surgery, and presents with altered sensation in the upper medial thigh, particularly under the inguinal ligament, and can also result in an absent cremasteric reflex. Now listen carefully to the lateral femoral cutaneous nerve, which originates from L2 and L3. It is purely sensory, supplying the anterior and lateral thigh. This nerve can be compressed by tight clothing, obesity, pregnancy, or pelvic procedures, leading to a condition called neuralgia paresthetica, where the patient feels tingling, numbness, or burning pain in the anterolateral thigh. Let's now consider the obturator nerve, which comes from L2 to L4. Sensory innervation is to the medial thigh, and motor innervation is to the obturator externus, adductor longus, adductor brevis, gracilis, pectineus, and adductor magnus. It can be injured during pelvic operations, resulting in decreased thigh sensation medially, and impaired adduction of the thigh. Now we move to the femoral nerve, which also arises from L2 to L4. It provides sensory innervation to the anterior thigh and medial leg, and motor control to the quadriceps, iliacus, pectineus, and sartorius. It is susceptible to injury from pelvic fractures, retroperitoneal hematomas, or psoas abscesses, and presents with decreased leg extension and a reduced patellar reflex. Now listen carefully, we finish with the sciatic nerve, arising from L4 to S3. It gives sensory innervation to the posterior thigh, posterior knee, and everything below the knee, except a narrow medial strip of the lower leg. It controls the semitendinosus, semimembranosus, biceps femoris, and part of the adductor magnus. This nerve can be injured by a herniated disc, posterior hip dislocation, or piriformis syndrome, and eventually splits into the common peroneal and tibial nerves, affecting many downstream structures. Now listen carefully, starting with the common fibular nerve, also called the common peroneal nerve, which originates from L4 to S2. It divides into two branches, the superficial peroneal nerve and the deep peroneal nerve. The superficial branch supplies sensory innervation to the dorsum of the foot, except for the web space between the hallux and the second digit, and gives motor control to the peroneus longus and peroneus brevis. Meanwhile, the deep peroneal nerve provides sensory input specifically to that web space between the hallux and second digit, and it also powers the tibialis anterior muscle. Now let's talk about injuries. This nerve can be damaged by trauma or compression to the lateral aspect of the leg, especially from a fibular neck fracture. You should remember this, PED means peroneal everts and dorsiflexes, so if it's injured, the foot is dropped. This causes loss of sensation on the dorsum of the foot, and foot drop results in the foot being inverted and plantarflexed at rest, with loss of eversion and dorsiflexion, and the person may develop a steppage gait to compensate. Now let's shift to the tibial nerve, which comes from L4 to S3. It provides sensory innervation to the sole of the foot, and motor control to the biceps femoris long head, the triceps shuri, the plantaris, the popliteus, and all the flexor muscles of the foot. Injury can occur due to knee trauma, a Baker's cyst if the lesion is proximal, or tarsal tunnel syndrome if the lesion is distal. You should remember this too. TIP stands for tibial inverts and plantarflexes, so if it's injured, the patient can't stand on their tiptoes. Now listen carefully, tibial nerve injury leads to inability to curl the toes, and loss of sensation on the sole. In proximal lesions, the foot is often everted at rest, with weakened inversion and plantarflexion, making walking difficult and unstable. This nerve plays a major role in weight bearing and balance, so injuries can be especially disabling. Now let's talk about the superior gluteal nerve, arising from L4 to S1, which provides motor control to the gluteus medius, gluteus minimus, and tensor fasciae lati. It is often injured iatrogenically, especially during intramuscular injections into the supromedial gluteal region, which is why injections should instead be given in the superolateral quadrant, preferably the anterolateral region. When injured, it leads to the Trendelenburg sign or Trendelenburg gait, where the pelvis tilts because the weight-bearing leg can't maintain proper alignment of the pelvis during hip abduction. Now listen, in this case, the lesion is located on the side of the raised hip, and it is ipsilateral to the standing leg. This means that if the right leg is the weight-bearing leg and the left hip drops, the injury is on the right side. Patients may sway or lurch while walking, and compensatory trunk movements often develop to maintain balance. Now let's turn to the inferior gluteal nerve, which arises from L5 to S2, and provides motor innervation exclusively to the gluteus maximus. This nerve may be injured during a posterior hip dislocation, and the patient may have difficulty climbing stairs, rising from a seated position, or performing any action that requires hip extension, due to weakness of the gluteus maximus. Finally, let's talk about the pudendal nerve, which comes from S2 to S4. It gives sensory innervation to the perineum, and motor innervation to the external urethral and anal sphincters. Injury can occur due to stretching during childbirth, prolonged cycling, or horseback riding, and it presents with reduced sensation in the perineum and genital area, possibly leading to fecal and urinary incontinence. Are you following me? The pudendal nerve can be blocked with local anesthetic during childbirth, using the ischial spine as a landmark for precise injection. Now let's talk about ankle sprains, starting with the most common type, which involves the anterior talofibular ligament. This is classified as a low ankle sprain, and it usually results from overinversion or supination of the foot. On the other hand, the anterior inferior tibiofibular ligament is the most commonly injured in high ankle sprains, often referred to as high tide sprains. You should remember this contrast: low ankle sprains are more frequent and involve inversion, while high ankle sprains affect the syndesmotic ligaments between the tibia and fibula. Now listen carefully, several other ligaments contribute to ankle stability. These include the posterior inferior tibiofibular ligament, the posterior talofibular ligament, the calcaneofibular ligament, and again the anterior talofibular ligament, which is commonly damaged. Important bones in this region include the fibula, the tibia, and the talus, along with tarsals, metatarsals, and phalanges. The calcaneus, cuboid, navicular, and the cuneiform bones also play structural roles in the foot, especially under mechanical stress. Now let's shift to lumbosacral radiculopathy, which is characterized by paresthesia and weakness related to specific lumbosacral spinal nerves. What causes this? The intervertebral disc, specifically the nucleus pulposus, often herniates posterolaterally through the annulus fibrosus, which is the tough outer ring. This happens because the posterior longitudinal ligament is thinner compared to the thicker anterior longitudinal ligament, especially along the midline of the vertebral bodies. Now listen closely, the nerve root affected is usually the one that lies below the level of herniation. Diagnostic signs include a positive straight leg raise, a positive contralateral straight leg raise, and a positive reverse straight leg raise, which is also known as the femoral stretch test. Anatomical features like the L4 and L5 pedicles, L4 and L5 bodies, and L4, L5, S1, and S2 nerve roots are important landmarks when assessing disc protrusions. Common disc levels affected are L4, L5 and L5, S1, leading to compressive symptoms in the L5 and S1 nerve roots, respectively. Now let's talk about specific disc herniation levels and their clinical findings. When there's a herniation at L3, L4, the L4 nerve root is affected, causing weakness in knee extension and a decreased patellar reflex. At L4, L5, you see L5 nerve root involvement, leading to weakness of dorsiflexion and difficulty in heel walking. At L5, S1, the S1 nerve root is compressed, resulting in weakness of plantar flexion, difficulty in toe walking, and a decreased Achilles reflex. These clinical features help pinpoint the exact level of nerve involvement. Now let's finish with neurovascular pairing, where nerves and arteries are often named according to their location near specific bones or anatomical regions. However, some key exceptions exist. In the axilla or lateral thorax, the long thoracic nerve pairs with the lateral thoracic artery. At the surgical neck of the humerus, the axillary nerve pairs with the posterior circumflex artery. Around the mid-shaft of the humerus, the radial nerve runs with the deep brachial artery, while in the cubital fossa, the median nerve is paired with the brachial artery. Listen carefully, in the popliteal fossa, the tibial nerve travels alongside the popliteal artery, and finally, posterior to the medial malleolus, the tibial nerve runs with the posterior tibial artery. These pairings are important in trauma, surgical planning, and clinical assessment of vascular or nerve injuries, especially in regions where compartments are tightly packed and vulnerable to compression. T-tubules are extensions of plasma membrane in contact with the sarcoplasmic reticulum, allowing for coordinated contraction of striated muscles, and now listen carefully, the action potential opens presynaptic voltage-gated calcium channels, inducing acetylcholine, or ACH, release, while postsynaptic ACH binding leads to muscle cell depolarization at the motor end plate. Depolarization travels over the entire muscle cell, and deep into the muscle via the T-tubules, and membrane depolarization induces conformational changes in the voltage-sensitive dihydropyridine receptor, or DHPR, and its mechanically coupled ryanodine receptor, or RR, promoting calcium release from the sarcoplasmic reticulum, buffered by calsequestrin, into the cytoplasm. Now let's talk about what happens next. As tropomyosin is blocking myosin-binding sites on the actin filament, the released calcium binds to troponin C, or TNC, shifting tropomyosin to expose the myosin-binding sites, then the myosin head binds strongly to actin forming a crossbridge, and inorganic phosphate, or PI, is released, initiating the power stroke. During the power stroke, force is produced as myosin pulls on the thin filament, and muscle shortening occurs, with shortening of the H and I bands and between the Z lines, and remember this phrase, "Chai, I'm wearing shorts," to recall that the A band remains the same length, and ADP is released at the end of the power stroke. Binding of a new ATP molecule causes detachment of the myosin head from the actin filament, and calcium is resequestered, then ATP hydrolysis into ADP and PI results in the myosin head returning to its high-energy position, known as the cocked state, and the myosin head can bind to a new site on actin to form another crossbridge, if calcium remains available. Now listen carefully, reuptake of calcium by the plasmic reticulum calcium ATPase, also called SERCA, promotes muscle relaxation, and throughout this process, coordination between electrical and mechanical components ensures effective muscle contraction and controlled relaxation, tightly regulated and energetically dependent. Listen doctors, there are two types of skeletal muscle fibers, normally distributed randomly within muscle, and muscle fiber type grouping commonly occurs due to reinnervation of denervated muscle fibers in peripheral nerve damage, and these types are known as type 1 and type 2. Type 1 fibers have slow contraction velocity, red fiber color, and their predominant metabolism is oxidative phosphorylation, which supports sustained contraction, while type 2 fibers have fast contraction velocity, white fiber color, and rely on anaerobic glycolysis, suited for short bursts of activity. Let's go deeper. Type 1 fibers are associated with endurance training and high amount of mitochondria and myoglobin, while type 2 fibers adapt to weight or resistance training and sprinting and low amount of mitochondria and myoglobin, and an easy way to remember them is to think, 1 slow red ox, for type 1, and 2 fast white antelopes, for type 2, helping reinforce their contrasting functions. Now let's talk about skeletal muscle adaptations, where atrophy and hypertrophy represent opposite responses. In atrophy, myofibrils are reduced through removal via the ubiquitin proteasome system, while in hypertrophy, myofibrils increase by addition of sarcomeres in parallel. In the same way, during atrophy, myonuclei decrease due to selective apoptosis, but in hypertrophy, they increase through the fusion of satellite cells, which repair damaged myofibrils, and this fusion process is absent in cardiac muscles, making skeletal muscle unique in its repair mechanisms. Are you following me? Let's move to vascular smooth muscle contraction and relaxation, where contraction begins with membrane depolarization and an action potential, increasing intracellular calcium, which then forms a calcium-calmodulin complex and activates myosin light chain kinase, or MLCK. This activation leads to phosphorylation of myosin, allowing it to bind to actin, resulting in contraction, while on the other hand, nitric oxide, or NO, promotes relaxation, through a cascade involving GTP conversion into cGMP, which activates myosin light chain phosphatase, or MLCP, reversing phosphorylation and ending contraction. And finally, remember these exact key players: acetylcholine, bradykinin, L-type voltage-gated calcium channels, calcium ions, nitric oxide synthase, myosin light chain kinase, and myosin light chain phosphatase, all working in balance to determine whether vascular smooth muscle contracts or relaxes. Now listen carefully. Muscle proprioceptors are specialized sensory receptors that relay information about muscle dynamics, and these include muscle stretch receptors and the Golgi tendon organ, each with distinct roles in sensing and responding to changes in muscle condition. The pathway for muscle stretch receptors involves sensing the length and speed of stretch, sending signals via the dorsal root ganglion, or DRG, leading to activation of inhibitory interneurons and alpha motor neurons, and this results in simultaneous inhibition of the antagonist muscle to prevent overstretching, and activation of the agonist muscle to promote contraction. In contrast, the Golgi tendon organ responds to muscle tension, also sending signals through the DRG, activating inhibitory interneurons that then inhibit the agonist muscle, helping reduce tension within the muscle and tendon, protecting against potential damage. Let's talk about their location and innervation, because muscle stretch receptors are located in the body of the muscle and are innervated by type Ia and type II sensory axons, while the Golgi tendon organs are located in the tendons and are innervated by type Ib sensory axons. Now listen carefully. The activation of muscle stretch receptors is triggered by muscle stretch, and they are responsible for deep tendon reflexes, while the Golgi tendon organs are activated by muscle tension, forming a protective feedback loop to prevent excessive force. And to visualize this clearly, remember the pathway through the dorsal root to the interneuron, then through alpha fibers to the agonist or antagonist muscles, whether from Ia and II fibers of the muscle spindle or Ib fibers from the Golgi tendon organ, forming coordinated loops of sensory input and motor output. Are you following me? Now let's transition to bone formation, starting with endochondral ossification, which forms bones of the axial skeleton, appendicular skeleton, and the base of the skull, beginning as a cartilaginous model made by chondrocyte, then replaced by woven bone through the action of osteoclasts and osteoblasts, and finally remodeled to lamellar bone. In adults, woven bone appears after fractures and in Paget disease, and it's important to note that endochondral ossification is defective in achondroplasia, while in membranous ossification, bones of the calvarium, facial bones, and clavicle are formed directly as woven bone without a cartilage model, and are later remodeled into lamellar bone. Let's talk about the cell biology of bone, beginning with the osteoblast, which builds bone by secreting collagen and catalyzing mineralization in an alkaline environment, through the action of alkaline phosphatase, or ALP. Osteoblasts differentiate from mesenchymal stem cells located in the periosteum, and their activity is measured by bone ALP, osteocalcin, and propeptides of type I procollagen. Next, let's focus on the osteoclast, which dissolves, or crushes, bone by secreting hydrogen ions and collagenases. Osteoclasts differentiate from a fusion of monocyte or macrophage lineage precursors, and they express rank receptors that are stimulated by RNKL, or rank ligand, which is expressed on osteoblasts. Meanwhile, osteoprotegerin, or OPG, acts as a decoy receptor for RNKL, preventing the rank-RNKL interaction and thus reducing osteoclast activity. Are you listening me? Now listen carefully. Parathyroid hormone, or PTH, at low intermittent levels, exerts anabolic effects, meaning it helps build bone, by acting on osteoblasts and, indirectly, on osteoclasts. But, when PTH levels remain chronically elevated, as in primary hyperparathyroidism, it leads to catabolic effects, such as osteitis fibrosa cystica, characterized by excessive bone resorption. Now let's shift to estrogen, which plays a vital role in bone homeostasis by inhibiting apoptosis in bone-forming osteoblasts, and inducing apoptosis in bone-resorbing osteoclasts. It also causes closure of the epiphyseal plate during puberty, and when estrogen levels drop, whether surgically or after menopause, it increases cycles of bone remodeling and resorption, raising the risk of osteoporosis. To visualize the bone remodeling process, think of the interaction between osteoclast precursors and rank on their surfaces, with RANKL on osteoblasts driving differentiation, while OPG from osteoblasts interrupts this interaction, thus modulating the balance between bone formation and resorption. Now let's change gears and talk about pathology. Starting with overuse injuries of the elbow. Medial, or golfer's elbow tendinopathy, results from repetitive wrist flexion or can be idiopathic, and leads to pain near the medial epicondyle. On the other hand, lateral, or tennis elbow tendinopathy, is associated with repetitive wrist extension, like in backhand shots, or may also be idiopathic, causing pain near the lateral epicondyle. Clavicle fractures is common in children and as birth trauma. It is usually caused by a fall on outstretched hand or by direct trauma to shoulder. Weakest point is at the junction of middle and lateral thirds. Fractures at the middle third segment are most common. Clavicle fracture presents as shoulder drop, shortened clavicle. This is due to lateral fragment is depressed due to arm weight and medially rotated by arm adductors, for example by pectoralis major. Let's advance with wrist and hand injuries, starting with Guyon canal syndrome, which involves compression of the ulnar nerve at the wrist. This condition is classically seen in cyclists due to pressure from handlebars, but it may also be seen with fracture or dislocation of the hook of hamate. Next, are you ready? We have carpal tunnel syndrome, which results from entrapment of the median nerve in the carpal tunnel, located between the transverse carpal ligament and the carpal bones. This leads to nerve compression, followed by paresthesia, pain, and numbness in the distribution of the median nerve. The thenar eminence atrophies, but sensation is spared because the palmar cutaneous branch enters the hand external to the carpal tunnel. This condition is suggested by a positive Tinel sign, where percussion of the wrist causes tingling, and a positive Phelan maneuver, where 90-degree flexion of the wrist causes tingling. Now listen carefully. Carpal tunnel syndrome is associated with pregnancy due to edema, rheumatoid arthritis, hypothyroidism, diabetes, acromegaly, and dialysis-related amyloidosis, and may also be related to repetitive use. Moving forward, let's talk about metacarpal neck fracture, most commonly involving the fifth metacarpal, also called a boxer's fracture. This typically occurs in young males due to direct trauma, for example, punching a wall. It presents with pain, swelling, and tenderness over the affected metacarpal, reduced grip strength, and possible deformity. Now let's shift our attention to the psoas abscess, which is a collection of pus in the iliopsoas compartment. This infection may spread from the blood through hematogenous dissemination, or from adjacent structures such as vertebral osteomyelitis, tuberculous spondylitis, also known as pot disease, or pyelonephritis. It is associated with Crohn's disease, diabetes, and immunocompromised states. Staphylococcus aureus is the most commonly isolated organism, but the abscess may also occur secondary to tuberculosis. The findings include flank pain, fever, an inguinal mass, and a positive psoas sign, where hip extension exacerbates lower abdominal pain. You should remember this. Labs will show leukocytosis, and imaging through CT or MRI will reveal a focal hypodense lesion within the muscle plane, marked by a red arrow. Treatment consists of abscess drainage and administration of antibiotics. Let's continue with common knee conditions, and first we have the unhappy triad, which is a common injury in contact sports caused by a lateral force impacting the knee when the foot is planted firmly on the ground. This injury consists of damage to the anterior cruciate ligament, abbreviated as ACL, the medial collateral ligament or MCL, and the medial meniscus, which is attached to the MCL. However, listen carefully, lateral meniscus involvement is actually more common than medial meniscus involvement when it occurs alongside ACL and MCL injuries. This condition presents with acute pain and clear signs of joint instability. Talking about prepatellar bursitis, which is inflammation of the prepatellar bursa located right in front of the kneecap. This condition can be caused by repeated trauma or pressure from excessive kneeling, which is why it's often referred to as housemaid's knee. Imaging may show the inflamed bursa with a red arrow pointing to the affected area. Moving on, we come to the popliteal cyst, also known as a Baker cyst. This involves a popliteal fluid collection, visible in the gastrocnemius semimembranosus bursa, and it commonly communicates with the synovial space. This type of cyst is usually related to chronic joint diseases such as osteoarthritis or rheumatoid arthritis. Shifting to common musculoskeletal conditions, starting with costochondritis, which is inflammation of the costochondral or costosternal junctions. It presents with focal tenderness to palpation and sharp, positional chest pain that may worsen with deep inspiration. This condition is more common in younger female patients and can mimic more serious cardiac or pulmonary diseases, such as myocardial infarction or pulmonary embolism. Now listen closely, the Quervain tenosynovitis involves non-inflammatory thickening of the abductor pollicis longus and extensor pollicis brevis tendons. This causes pain or tenderness at the radial styloid and is confirmed with a positive Finkelstein test, where pain at the radial styloid occurs with active or passive stretching of the thumb tendons. This condition is more common in new mothers from lifting a baby, and also in golfers, racket sport players, and frequent texters using their thumbs. Next, we have Dupuytren contracture, which is caused by fibroblastic proliferation and thickening of the superficial palmar fascia. It typically affects the fascia at the base of the ring and little fingers. While the exact cause is unknown, it most frequently occurs in males over 50 years old, especially those of Northern European descent. Are you following me? Now let's talk about the ganglion cyst, which is a mucin-filled swelling that appears over joints or tendon sheaths, most commonly on the dorsal side of the wrist. It transilluminates when exposed to shining light, a feature that helps differentiate it from tumors, which do not. Thankfully, ganglion cysts usually resolve spontaneously without treatment. Let's keep going with iliotibial band syndrome, which is an overuse injury of the lateral knee, occurring primarily in runners. The pain develops due to friction of the iliotibial band against the lateral femoral epicondyle, making it a common problem for athletes. Now listen carefully, limb compartment syndrome involves increased pressure within a facial compartment of a limb. This pressure leads to venous outflow obstruction and collapse of arterioles, which causes anoxia, necrosis, and rhabdomyolysis. This, in turn, can result in acute tubular necrosis. Causes include significant long bone fractures, such as of the tibia, reperfusion injury, or even animal venom. It presents with severe pain, tense and swollen compartments, and pain on passive muscle stretch. Increased serum creatine kinase and motor deficits are late signs of irreversible muscle and nerve damage. The 5 Ps you should remember are pain, pallor, paresthesia, pulselessness, and paralysis. Next, we move on to medial tibial stress syndrome, commonly known as shin splints. This is a common cause of shin pain and diffuse tenderness, especially in runners and military recruits. It is caused when bone resorption outpaces bone formation in the tibial cortex, leading to pain and microdamage. Finally, we come to plantar fasciitis, which is inflammation of the plantar aponeurosis. This condition is characterized by heel pain that is worse with the first steps in the morning or after a period of inactivity. It is associated with obesity, prolonged standing or jumping, as seen in dancers and runners, and flat feet. Heel spurs often coexist with this condition. And to close this section, let's talk about temporomandibular disorders, which involve the temporomandibular joint and the muscles of mastication. The cause is multifactorial and includes TMJ trauma, poor head and neck posture, abnormal trigeminal nerve pain processing, and psychological factors. These disorders present with dull, constant, unilateral facial pain that worsens with jaw movement, as well as otalgia, headache, and TMJ dysfunction, such as limited range of motion. Now listen carefully, radial head subluxation, also called nursemaid's elbow, is a common elbow injury in children younger than 5 years. It's caused by a sudden pull on the arm, which leads to the immature annular ligament slipping over the head of the radius. Because of this, the injured arm is usually held in a slightly flexed and pronated position, and although it sounds simple, it can be very painful and alarming for parents. Moving on to Musculoskeletal disease, also known as traction apophysitis, this is an overuse injury due to repetitive strain and chronic avulsion of the secondary ossification center of the tibial tuberosity. It typically affects adolescents after a growth spurt, especially those involved in sports that include running and jumping, and presents with progressive anterior knee pain. Now let's talk about patellofemoral syndrome, an overuse injury that's commonly seen in young, female athletes and presents as anterior knee pain. This pain is worsened by prolonged sitting or bearing weight on a flexed knee, and while it may not seem serious at first, it can significantly affect athletic performance and comfort. Next, developmental dysplasia of the hip is due to abnormal acetabulum development in newborns. A major risk factor here is breech presentation, and the result is hip instability or even dislocation. Diagnosis is usually by physical examination using the Ortolani and Barlow maneuvers, where manipulation of the newborn's hip may reveal a clunk, and confirmation is done by ultrasound since X-ray isn't used until around 4 to 6 months due to unossified cartilage. Are you following me? Now let's move on to Legg-Calvé-Perthes disease, which is idiopathic avascular necrosis of the femoral head. This condition commonly presents between 5 to 7 years of age, often more in males with a 4-to-1 ratio, and has an insidious onset of hip pain that may cause the child to limp. Interestingly, the initial X-ray might appear normal, which can delay diagnosis. Slipped capital femoral epiphysis is next, and it classically presents in an obese young adolescent with hip or knee pain and an altered gait. Increased axial force on the femoral head causes the epiphysis to displace relative to the femoral neck, just like a scoop of ice cream slipping off a cone. Now let's explore common pediatric fractures, beginning with the green stick fracture, which is an incomplete fracture extending partway through the bone following bending stress. The bone fails on the tension side while the compression side remains intact, making it look like a green twig being bent, hence the name. Then we have the torus or buccal fracture, caused by axial force applied to immature bone. This leads to the cortex buckling on the compression side while the tension side remains solid and intact. When comparing with complete fractures, these are typically less severe but still require proper management. Now listen carefully, achondroplasia is a failure of longitudinal bone growth through endochondral ossification, which leads to short limbs. However, membranous ossification is not affected, so the head appears large relative to the limbs. This condition results from constitutive activation of the fibroblast growth factor receptor, FGFR3, which inhibits chondrocyte proliferation. More than 85% of mutations occur sporadically, and it's inherited in an autosomal dominant fashion with full penetrance. Homozygosity is lethal. It's also associated with increased paternal age and is the most common cause of short-limbed dwarfism. Are you ready for more? Osteoporosis is next, and here, trabecular and cortical bone lose mass, despite normal bone mineralization and lab values for calcium and phosphate. It's most commonly due to increased bone resorption due to increased osteoclast number and activity linked to reduced estrogen, aging, and cigarette smoking. It can also be secondary to drugs like steroids and alcohol, anticonvulsants, anticoagulants, thyroid replacement therapy or conditions such as hyperparathyroidism, malabsorption, multiple myeloma weight loss and anorexia. It can also be caused by prolonged microgravity exposure like aerospace travel. Now listen carefully, diagnosis is made by bone mineral density measurement using DEXA, or dual-energy X-ray absorptiometry, and it is performed at the lumbar spine, the total hip, and the femoral neck, with a t-score of less than or equal to -2.5, or by identifying a fragility fracture, such as a fall from standing height, or from minimal trauma, specifically at the hip or vertebra. One-time screening is recommended in females who are 65 years or older, and this step is vital for early detection. For prophylaxis, regular weight-bearing exercise is essential, and adequate calcium and vitamin D intake must be ensured throughout adulthood. Now let's talk about treatment, because this is crucial. Options include bisphosphonates, teriparatide or abaloparatide, selective estrogen receptor modulators or SERMs, and denosumab, which is a monoclonal antibody against RANKL, and also romosozumab, a sclerostin inhibitor. Remember this, osteoporosis can lead to vertebral compression fractures, which present as acute back pain, loss of height, and kyphosis, and fractures may also occur at the femoral neck or distal radius, which is known as a Coles fracture. Are you following me? Let's move on to osteopetrosis, a condition defined by failure of normal bone resorption due to defective osteoclasts, which leads to thickened, dense bones that are paradoxically prone to fracture. Mutations, for example in the carbonic anhydrase II gene, impair the osteoclast's ability to generate the acidic environment necessary for resorbing bone. Overgrowth of cortical bone eventually fills the marrow space, causing pancytopenia and even extramedullary hematopoiesis, which are serious complications. Now listen carefully again, this bone overgrowth can also result in cranial nerve impingement and palsies, due to narrowing of the skull foramina. On X-ray, we see diffuse symmetric sclerosis, often described as bone-in-bone or stone bone. The good news is, bone marrow transplant can be curative, since osteoclasts are derived from monocytes, making the transplant functionally restorative. Are you ready to learn more? Let's talk about osteomalacia and rickets, conditions involving defective mineralization of osteoid in adults, and defective mineralization of cartilaginous growth plates in children. The most common cause is vitamin D deficiency, which leads to undermineralized bone matrix. X-rays in osteomalacia show osteopenia and pseudofractures, while in rickets, you'll find epiphyseal widening and metaphyseal cupping or fraying. Children with rickets often have pathologic bow legs, also called genu varum, along with bead-like costochondral junctions referred to as rachitic rosary, and a soft skull known as craniotapes. Decreased vitamin D results in decreased serum calcium, leading to increased parathyroid hormone secretion, which then lowers serum phosphate. Hyperactivity of osteoblasts leads to increased alkaline phosphatase or ALP, which is another diagnostic clue. Now let's shift to osteitis deformans, also known as Paget disease of bone, which is a common and localized disorder of bone remodeling. It begins with increased osteoclastic activity, followed by increased osteoblastic activity that forms poor-quality bone, yet serum calcium, phosphate, and parathyroid hormone levels are usually normal. However, alkaline phosphatase levels are elevated, and you may see a mosaic pattern of woven and lamellar bone, with osteocytes arranged chaotically within lacunae. Now listen carefully, long bones may fracture in a chalk-stick pattern, and the increased blood flow from arteriovenous shunts can cause high-output heart failure. There's also an increased risk of osteosarcoma. Hat size may increase due to skull thickening, and hearing loss is common due to skull deformities. The disease has stages, an early destructive or lytic phase with osteoclasts, an intermediate mixed phase with both osteoclasts and osteoblasts, and a late sclerotic or blastic phase dominated by osteoblasts. It may eventually enter a quiescent phase, and treatment is with bisphosphonates. Now listen carefully, avascular necrosis of bone is defined as infarction of the bone and marrow, and it is usually very painful. The most common site is the femoral head, which is considered a watershed area, due to the insufficiency of blood supply from the medial circumflex femoral artery. Causes of this condition include glucocorticoids, chronic alcohol overuse, sickle cell disease, trauma, systemic lupus erythematosus, and the bends, which refers to caisson or decompression disease. You should also remember Legg-Calvé-Perthes disease, which is idiopathic, and Gaucher disease, as well as slipped capital femoral epiphysis. A useful mnemonic is casts bend legs. Now let's look at the anatomy behind this, because it matters. This watershed area becomes infarcted when circulation fails. The medial femoral circumflex artery, which is posterior, plays a crucial role, and it branches from the obturator artery. In contrast, the lateral femoral circumflex artery comes from the anterior side. Knowing these anatomical distinctions is key to understanding why necrosis occurs in such specific locations. Are you following me? Because now we're moving to lab values in bone disorders, which are fundamental in differential diagnosis. In osteoporosis, calcium and phosphate are typically normal, and so are ALP and PTH, although if there's concurrent vitamin D deficiency, you may see increased PTH with normal calcium. In osteoporosis generally there is decreased bone mass. In osteopetrosis, calcium and phosphate are also normal or sometimes reduced, with normal ALP and PTH, but in severe, malignant disease, calcium may decrease. In this condition there is dense and brittle bone. Now let's talk about Paget disease of bone, where calcium, phosphate, and PTH are normal, but alkaline phosphatase is increased. There is also abnormal mosaic bone architecture. Osteitis fibrosa cystica from primary hyperparathyroidism shows increased calcium, decreased phosphate, elevated ALP, and elevated PTH. You'll see brown tumors from fibrous bone replacement and subperiosteal thinning. Causes may be idiopathic, or from parathyroid hyperplasia, adenoma, or carcinoma. Let's continue with secondary hyperparathyroidism, where calcium is decreased, phosphate is increased, and both ALP and PTH are elevated. This often arises as a compensation for chronic kidney disease, which decreases phosphate excretion and limits the production of activated vitamin D. In osteomalacia and rickets, due to vitamin D deficiency, calcium and phosphate are decreased, while ALP and PTH are increased, leading to soft bones and secondary hyperparathyroidism. In contrast, hypervitaminosis D shows increased calcium and phosphate, with normal ALP, and low PTH, and this may result from oversupplementation or granulomatous diseases like sarcoidosis. Now let's switch to primary bone tumors, and you should remember this: metastatic disease is more common than primary bone tumors. Benign bone tumors end with oma, and those that start with a C and an O are more common in boys, while malignant ones usually end in sarcoma. Starting with benign tumors, osteochondroma or exostosis is the most common benign bone tumor, seen in males under 25. It's usually found at the metaphysis of long bones, especially around the knee, like the distal femur. Now listen carefully. Osteochondroma presents as a lateral bony projection from the growth plate that is continuous with the marrow space and covered by a cartilaginous cap. It points away from the joint and may involve extension 1 or extension 2 gene mutations, known collectively as hereditary multiple exostoses. Rarely, it can transform into chondrosarcoma. Osteoma usually occurs in middle age, affecting the surface of facial bones, and it's associated with Gardner syndrome. Let's keep going. Osteoid osteoma affects adults younger than 25, with males more than females. It appears in the cortex of long bones and classically presents as bone pain worse at night, due to prostaglandin release, and it is relieved by NSAIDs, which distinguishes it from osteoblastoma. It presents as a bony mass smaller than 1.5 cm with a radiolucent osteoid core. Osteoblastoma, while similar in histology, is larger, more than 2 cm, and often affects the vertebrae, with pain that does not respond to NSAIDs. Now let's move on to giant cell tumor, seen in individuals aged 20 to 40, with females more than males. It affects the epiphysis of long bones after skeletal maturation, often in the knee region, and radiographically, the epicenter is the metaphysis. This tumor is locally aggressive and benign, composed of neoplastic mononuclear cells expressing RANKL, and reactive multinucleated giant osteoclast-like cells. It is also known as osteoclastoma and appears as a soap bubble on X-ray. Finally, let's discuss chondroblastoma, which affects adolescents, more commonly males than females, and it involves the epiphysis of long bones before skeletal maturation. Patients may complain of joint pain, and on X-ray, the lesion can cross the physis. Now listen carefully. Malignant tumors of the bone start with osteosarcoma, also known as osteogenic sarcoma. This tumor accounts for 20% of primary bone cancers and has a peak incidence in males under 20 years of age. Though it's less common in older adults, when it does occur, it's usually secondary to predisposing factors like Paget disease of bone, bone infarcts, prior radiation, familial retinoblastoma, or Li-Fraumeni syndrome. It typically arises in the metaphysis of long bones, most often around the knee region. Are you following me? Histologically, osteosarcoma shows pleomorphic osteoid-producing cells, which are malignant osteoblasts. It presents as a painful, enlarging mass or sometimes with pathologic fractures. You should remember the Codman triangle, formed from periosteal elevation, and the sunburst pattern on X-ray, which is classically described as an osteocod swimming in the sun. It's an aggressive tumor, but primary osteosarcoma is usually responsive to surgery and chemotherapy. However, secondary osteosarcoma carries a poor prognosis. Now let's talk about chondrosarcoma, which is most common in adults over 50 years old. It arises in the medulla of bones such as the pelvis, the proximal femur, and the humerus. This is a tumor of malignant chondrocyte, and more than half of the cases show lytic lesions with intralesional calcifications. You may also see endosteal erosion and cortical breach. The clinical presentation and radiographic findings make chondrosarcoma a serious malignancy requiring thorough assessment. Next up is Ewing sarcoma, and you should remember this: it is most common in white male patients younger than 15 years. It arises in the diaphysis of long bones, especially the femur, and also in the pelvic flat bones. Microscopically, you'll find anaplastic small blue cells of neuroectodermal, or mesenchymal, origin. These cells resemble lymphocytes, so it's essential to differentiate from similar conditions like lymphoma or chronic osteomyelitis. Now listen carefully, the hallmark genetic feature is the translocation T1122, which results in the fusion protein EWS-FLI1. Radiographically, you'll often see the onion skin periosteal reaction. Although aggressive and prone to early metastasis, Ewing sarcoma responds well to chemotherapy. And here's a fun way to remember: 11 plus 22 equals 33, the jersey number of Patrick Ewing. Are you ready to compare joint diseases? Let's start with osteoarthritis and rheumatoid arthritis. Osteoarthritis results from chronic mechanical stress that destroys articular cartilage, followed by inadequate repair, and this process is mediated by chondrocyte. In contrast, rheumatoid arthritis is autoimmune, where inflammation induces the formation of proliferative granulation tissue, which erodes both cartilage and bone. Now let's break down the predisposing factors. For osteoarthritis, these include age, being female, obesity, and joint trauma. For rheumatoid arthritis, risk factors include being female, having HLA-DR4 or HLA-DRB1, and smoking. It's associated with positive rheumatoid factor, which is an IgM antibody targeting IgG-Fc in about 80% of cases, and the anticyclic citrullonated peptide antibody, which is even more specific. When it comes to symptoms, osteoarthritis causes pain in weight-bearing joints after use, which improves with rest. The involvement is asymmetric and there are no systemic symptoms. In rheumatoid arthritis, however, you'll see pain, swelling, and morning stiffness lasting over an hour, which improves with use. The joint involvement is symmetric and accompanied by systemic features like fever, fatigue, and weight loss. Extra-articular manifestations may also appear. Now let's talk about joint findings. In osteoarthritis, expect to see osteophytes or bone spurs, asymmetric joint space narrowing, subchondral sclerosis, cysts, and loose bodies. Synovial fluid is non-inflammatory, with white blood cell counts under 2000 per cubic millimeter. You may see Heberden nodes at the distal interphalangeal joints, Bouchard nodes at the proximal interphalangeal joints, and involvement of the first carpometacarpal joint. Now listen carefully, rheumatoid arthritis shows erosions, juxtaarticular osteopenia, soft tissue swelling, symmetric joint space narrowing, and subchondral cysts. Deformities include cervical subluxation, ulnar deviation of the fingers, swan neck deformity, and boutonniere deformity. It typically involves the metacarpophalangeal joints, proximal interphalangeal joints, and wrists. For treatment, osteoarthritis is managed with activity modification, NSAIDs, and short-term intra-articular glucocorticoids, though long-term use carries many adverse effects. Rheumatoid arthritis is treated with NSAIDs, glucocorticoids, disease-modifying agents like methotrexate and sulfasalazine, and biologic agents such as TNF-alpha inhibitors. Finally, let's mention the extra-articular manifestations of rheumatoid arthritis. These include cervical subluxation, rheumatoid nodules with fibrinoid necrosis and palisading histiocytes, interstitial lung disease, pleuritis, pericarditis, anemia of chronic disease, and Felty syndrome. This is defined by splenomegaly, anemia, neutropenia, thrombocytopenia, and arthritis, remembered with the acronym SANTA. Other associations include AA amyloidosis, Sjogren's syndrome, scleritis, and carpal tunnel syndrome. Now listen carefully. Gout is an acute, inflammatory monoarthritis caused by the precipitation of monosodium urate crystals in joints, and the risk factors include male sex, hypertension, obesity, diabetes, dyslipidemia, and alcohol use, while the strongest risk factor is hyperuricemia, which can be caused by underexcretion of uric acid in 90% of patients. This is largely idiopathic, and is potentiated by renal failure, and can also be exacerbated by certain medications like thiazide. Diuretics, or by overproduction of uric acid, which occurs in 10% of patients, due to conditions like Lesch-Nyhan syndrome, PRPP-XS, or increased cell turnover such as in tumor lysis syndrome, and sometimes the mechanism is combined, as in alcohol use and von Gierke disease. You should remember this: these urate crystals are needle-shaped, and negatively birefringent under polarized light, appearing yellow when aligned parallel to the light and blue when perpendicular, while serum uric acid levels may actually be normal during an acute attack, so they're not always reliable indicators in the moment of inflammation. Are you following me? The symptoms show up with asymmetric joint distribution, where the affected joint becomes swollen, red, and painful, and the classic presentation is a painful MTP joint of the big toe, known as podagra, and tophi can also form, often on the external ear, the olecranon bursa, or the Achilles tendon, while acute attacks typically follow a large meal with purine-rich foods like red meat or seafood, or after trauma, surgery, dehydration, diuresis, or alcohol consumption, since increased blood lactate from alcohol metabolism enhances uric acid reabsorption and leads to hyperuricemia. Now let's talk about treatment, because during acute attacks, options include NSAIDs such as indomethacin, glucocorticoids, and colchicine, while for chronic prevention, patients are given allopurinol or probenecid, and for those who are overproducers, urate-lowering therapies like xanthine oxidase inhibitors, for example, allopurinol or febuxostat, are used to manage the condition long-term. Are you ready? Now let's shift to calcium pyrophosphate deposition disease, formerly called pseudogout, which involves the deposition of calcium pyrophosphate crystals within the joint space, typically in patients over 50 years old, and it affects both sexes equally, although it's usually idiopathic. Sometimes it's associated with conditions like hemochromatosis, hyperparathyroidism, or joint trauma. Here's what you should notice: the presentation involves pain and swelling, with either acute inflammation, referred to as pseudogout, or chronic degeneration, which resembles pseudoosteoarthritis, and the most commonly affected joint is the knee, with X-rays showing chondrocalcinosis or cartilage calcification, and the crystals themselves are rhomboid in shape, and weakly positively birefringent under polarized light, appearing blue when aligned parallel to the light. You should remember this: acute treatment includes NSAIDs, colchicine, or glucocorticoids, while prophylaxis involves continued colchicine, and the blue P's of CPPD are easy to recall: blue when parallel, positive birefringence, calcium pyrophosphate, and pseudogout, which helps distinguish it clearly. Now listen carefully. Systemic juvenile idiopathic arthritis is a systemic form of arthritis seen in children under 16 years old, and it usually presents with daily spiking fevers, a salmon-pink macular rash, and arthritis involving 2 or more joints, and it's also associated with anterior uveitis, while common lab findings include leukocytosis, thrombocytosis, anemia, elevated ESR, and high CRP. Are you following me? Sjogren's syndrome is an autoimmune disorder defined by the destruction of exocrine glands, especially lacrimal and salivary, by lymphocytic infiltrates, and it predominantly affects females between the ages of 40 and 60, and the findings include inflammatory joint pain, keratoconjunctivitis sicca with a gritty or sandy feeling in the eyes due to decreased tear production, and xerostomia, or reduced saliva production, leading to mucosal atrophy and fissuring of the tongue. Now let's talk specifics. These patients often have antinuclear antibodies, rheumatoid factor, and antiribonucleoprotein antibodies, such as SSA or anti-Rho, and SSB or anti-La, and some may experience dyspareunia, bilateral parotid enlargement, and note that anti-SSA and anti-SSB can also be seen in lupus. While Sjogren's syndrome may be a primary disorder or secondary to other autoimmune conditions like rheumatoid arthritis, lupus, or systemic sclerosis. Don't miss this. Complications include dental caries, mucosa-associated lymphoid tissue lymphoma, which may present as parotid enlargement, and an increased risk of giving birth to a baby with neonatal lupus, and confirmation of diagnosis can come from focal lymphocytic sialadenitis found on a labial salivary gland biopsy. Now listen carefully. Septic arthritis is most often caused by Staphylococcus aureus, Streptococcus, and Neisseria gonorrhoeae, and it usually affects a single joint, monoarticular involvement, where the joint becomes swollen, red, and painful, and synovial fluid is purulent with a white blood cell count over 50,000 per cubic millimeter. Here's what's critical. Complications include osteomyelitis, chronic pain, irreversible joint damage, and sepsis, and treatment involves antibiotics, aspiration, and drainage, with or without debridement, in order to prevent permanent damage, and disseminated gonococcal infection, which is an STI, may present as purulent arthritis in a joint like the knee or with a triad of polyarthralgia, tenosynovitis, especially in the hand, and dermatitis, such as pustules. Now finally, let's talk about osteomyelitis, which is a chronic or acute infection of the bone, and while Staphylococcus aureus is the most common cause overall, Staphylococcus epidermidis is more common in prosthetic infections, Salmonella is associated with sickle cell anemia, and Pseudomonas aeruginosa is linked to plantar puncture wounds, and the infection often spreads hematogenously in children, especially to the metaphysis of long bones, or exogenously in adults, usually due to trauma, surgery, or spread from nearby infected tissues. Now listen closely. Common symptoms include pain, redness, swelling, fever, and limping, and the diagnosis is made using imaging like X-ray, which may show bone destruction and periosteal elevation if chronic, or MRI, along with bone biopsy and blood cultures for definitive diagnosis, and treatment includes antibiotics, sometimes combined with surgery. Talking about seronegative spondyloarthritis, a form of arthritis without rheumatoid factor, meaning there's no anti-IgG antibody present, and this condition has a strong association with HLA-B27, which is a major histocompatibility complex class 1 serotype. The subtypes, often remembered by the acronym PAIR, share a variable occurrence of inflammatory back pain, which is usually worse in the morning, but improves with exercise, and is often accompanied by peripheral arthritis, enthesitis, which is inflammation at the insertion sites of tendons like the Achilles, dactylitis, also known as sausage fingers, and uveitis. Now listen carefully. The first subtype is psoriatic arthritis, which is associated with skin psoriasis and nail lesions, and usually shows asymmetric and patchy involvement. Dactylitis is common, and X-rays may reveal a penicillin cup deformity of the distal interphalangeal joints. Interestingly, this form is seen in fewer than one-third of patients with psoriasis, yet its radiographic and clinical presentation remains distinctive and important. Are you following me? Because now we're moving on to ankylosing spondylitis, which involves symmetric inflammation of the spine and sacroiliac joints, leading to ankylosis or joint fusion. Other features include uveitis and aortic regurgitation. The classic finding is a bamboo spine, indicating vertebral fusion, and costovertebral and costosternal ankylosis may cause restrictive lung disease. This condition is more common in males, with age of onset usually between 20 and 40 years. Shifting to the subtype linked with inflammatory bowel disease, where both Crohn's disease and ulcerative colitis are often associated with spondyloarthritis. This connection underscores the systemic nature of inflammatory bowel conditions, and highlights the overlap between gastrointestinal and musculoskeletal disorders in clinical practice, making a thorough review of systems essential when evaluating symptoms. You should remember this next one, reactive arthritis, which presents with a classic triad of conjunctivitis, urethritis, and arthritis. It's commonly associated with hyperkeratotic skin lesions on the palms and soles, a finding called keratoderma blennorrhagica. The phrase, "can't see, can't pee, can't bend my knee," is often used to remember it, and it's associated with infections by organisms like Shigella, Campylobacter, Salmonella, Chlamydia, and Yersinia. A helpful mnemonic is, "She caught students cheating yesterday and overreacted." Now listen carefully, we're discussing systemic lupus erythematosus, a systemic, remitting, and relapsing autoimmune disease, where organ damage is primarily due to a type 3 hypersensitivity reaction, and to a lesser extent, a type 2 hypersensitivity reaction. It's associated with a deficiency of early complement proteins like C1q, C4, and C2, leading to reduced clearance of immune complexes. Classic presentation includes facial rash that spares the nasolabial folds, joint pain, and fever in a female of reproductive age, with higher prevalence among Black, Caribbean, Asian, and Hispanic populations in the U.S. Are you ready for more? Because Liebman-Sachs endocarditis, abbreviated as LSE, is a type of non-bacterial endocarditis seen in SLE. Lupus nephritis, which involves glomerular deposition of DNA anti-DNA immune complexes, can present as either nephritic or nephrotic syndrome, causing hematuria or proteinuria, and the most common and severe type is diffuse proliferative. The main causes of death in SLE are renal disease, infections, and cardiovascular disease, especially due to accelerated coronary artery disease. A memorable phrase says, "Lupus patients die with redness in their cheeks." Now let's talk about pregnancy, because in an anti-SSA positive pregnant patient, there's an increased risk of the newborn developing neonatal lupus, which includes congenital heart block, periorbital or diffuse rash, transaminitis, and cytopenias at birth. And don't forget the helpful mnemonic rash or pain, which stands for rash, either malar or discoid, arthritis, non-erosive, serositis, such as pleuritis or pericarditis, hematologic disorders, like cytopenias, oral or nasopharyngeal ulcers, usually painless, renal disease, photosensitivity, antinuclear antibodies, immunologic disorders, such as anti-dsDNA, anti-SM, or antiphospholipid, and neurologic disorders, like seizures or psychosis. Are you following me? Let's move on to mixed connective tissue disease, which features overlapping symptoms of SLE, systemic sclerosis, and polymyositis, and is associated with anti-U1-RNP antibodies, showing a speckled ANA pattern. Now listen carefully, because antiphospholipid syndrome is an autoimmune disorder that can be primary or secondary, most commonly secondary to SLE. It's diagnosed based on clinical criteria such as a history of thrombosis, arterial or venous, or recurrent miscarriages, along with lab findings like lupus anticoagulant, anticardiolipin, or anti-beta-2-glycoprotein-1 antibodies. Treatment involves systemic anticoagulation to prevent further thrombotic events. Remember, anticardiolipin antibodies can cause false positive VDRL or RPR tests, and lupus anticoagulant can cause a prolonged PTT that is not corrected by adding normal platelet-free plasma. Polymyalgia rheumatica, now listen carefully, presents with pain and stiffness in proximal muscles, such as the shoulders and hips, and this is often accompanied by fever, malaise, and weight loss. It is important to remember that it does not cause muscular weakness, even though the discomfort may suggest otherwise. This condition is more common in females over 50 years old, and is notably associated with giant cell arteritis, also called temporal arteritis. When you investigate, you'll find increased ESR and CRP levels, but the creatine kinase remains normal, which is a distinguishing feature. The treatment involves a rapid response to low-dose glucocorticoids, and this can dramatically improve symptoms. Now let's talk about fibromyalgia, which is most commonly seen in females between 20 and 50 years old. This condition is marked by chronic, widespread musculoskeletal pain, often accompanied by specific tender points, and is also associated with stiffness, paresthesias, poor sleep, fatigue, and cognitive disturbances, commonly referred to as fibro-fog. Unlike inflammatory diseases, inflammatory markers such as ESR remain normal in fibromyalgia, which is a key diagnostic clue. For treatment, regular physical exercise plays a major role, and pharmacologic options include antidepressants like tricyclics and SNRIs, along with neuropathic pain agents such as gabapentinoids. Are you following me? Now listen carefully as we discuss polymyositis and dermatomyositis, two inflammatory myopathies that share certain features. Nonspecific findings include a positive ANA and elevated creatine kinase, while specific markers include anti-Jo1, which targets histidyltRNA synthetase, anti-SRP for signal recognition particle, and anti-Me2, which is a helicase. Polymyositis is characterized by progressive, symmetric proximal muscle weakness, and histologically by endometrial inflammation with CD8 plus T cells. This weakness most commonly affects the shoulders. Now let's shift to dermatomyositis, which is clinically similar to polymyositis but with additional distinctive skin findings. These include Gottron papules, photodistributed facial erythema such as heliotrope, which is a violaceous edema of the eyelids, and a shawl and face rash, which spreads over sun-exposed areas. You might also see mechanic's hands, which show thickening, cracking, and irregular, dirty-appearing marks due to hyperkeratosis of the digital skin. Dermatomyositis carries an increased risk of occult malignancy, and histologically, you will find paramecial inflammation and atrophy, involving CD4 plus T cells. Now listen carefully to this next condition, myositis ossificans. This involves heterotopic ossification within skeletal muscle, commonly in areas like the quadriceps, and is typically associated with blunt muscle trauma. It presents as a painful soft tissue mass, and when you image it, you may find eggshell calcification. On histology, there is metaplastic bone formation surrounding an area of fibroblastic proliferation. Although it is benign, it can sometimes be mistaken for a sarcoma, so clinical context and imaging are key to diagnosis. Finally, we must talk about IgG4-related disease, which is an immune-mediated spectrum of conditions marked by fibrosis and a lymphoplasmacytic infiltrate. It has the potential to affect multiple organs, and patients usually show elevated serum IgG4 levels. Among the most common manifestations are sialadenitis and dacryoadenitis, renal thyroiditis, autoimmune pancreatitis, and autoimmune aortitis, which can progress to thoracic or abdominal aortic aneurysms. Retroperitoneal fibrosis is another key manifestation, which may involve the ureters and lead to signs of acute kidney injury, chronic kidney disease, and even hydronephrosis. Vasculitides, are you following me, refer to inflammation and necrosis of blood vessels, and can be either idiopathic or immune-mediated, most commonly involving type 3 hypersensitivity reactions. Let's begin with large vessel vasculitis, and first among them is giant cell, or temporal arteritis, which typically affects females over 50 years old. Patients present with unilateral headache, jaw claudication, and temporal artery tenderness, and there is a significant risk of blindness due to anterior ischemic optic neuropathy. The pathology reveals granulomatous inflammation, affecting the temporal, vertebral, and ophthalmic arteries. This condition is associated with polymyalgia rheumatica. Key findings include a very high ESR and CRP, and confirmation is by temporal artery biopsy. However, treatment must begin promptly with high-dose glucocorticoids, even before biopsy results return. Now let's talk about Takayasu arteritis, which predominantly affects Asian females under the age of 40, and is famously known as pulseless disease, due to weak upper extremity pulses. Patients may also experience fever, night sweats, arthritis, and myalgias. The disease involves granulomatous thickening and narrowing of the aortic arch and its proximal great vessels. ESR is elevated, and the treatment of choice here is glucocorticoids. These large vessel vasculitides demonstrate how vessel size and systemic symptoms guide diagnosis and treatment. Now listen carefully as we move to medium vessel vasculitis, starting with Berger disease, also called thromboangiitis obliterans, which is strongly associated with heavy tobacco use, and typically affects males under 40 years of age. Clinical signs include intermittent claudication, increased risk of gangrene, Raynaud phenomenon, possible autoamputation of digits, or superficial nodular phlebitis. Histologically, This is a segmental thrombosing vasculitis with involvement of veins and nerves. There is no effective pharmacologic treatment, and smoking cessation is the most critical intervention. Are you ready for the next one? Kawasaki disease affects Asian children under the age of 4, and presents with bilateral non-exudative conjunctivitis, a polymorphous rash that desquamates, cervical adenopathy, a strawberry tongue due to oral mucositis, and changes in the hands and feet, such as edema and erythema. Fever must last 5 or more days to fulfill the criteria. The acronym CRASH and burn helps remember the features: conjunctivitis, rash, adenopathy, strawberry tongue, hand-foot changes, and fever. Complications can include coronary artery aneurysms, where thrombosis or rupture may be fatal. Treatment consists of intravenous immunoglobulin and aspirin. Now listen carefully, as we discuss polyarteritis nodosa, which most commonly affects middle-aged males, and is associated with hepatitis B seropositivity in about 30% of cases. Clinical findings include fever, weight loss, abdominal pain, melena, hypertension, neurologic dysfunction, cutaneous eruptions, and renal damage. It involves renal and visceral vessels while notably sparing the lungs, and histologically, it shows transmural inflammation with fibrinoid necrosis. Arteriograms reveal a string of pearls appearance due to microaneurysms. The standard treatment involves glucocorticoids and cyclophosphamide. Remember, PAN often targets the skin, kidneys, intestines, and nerves. Now let's shift to small vessel vasculitis, starting with microscopic polyangiitis, which typically affects middle-aged adults. It is a necrotizing vasculitis involving the lungs, kidneys, and skin, and often presents with pauciimmune glomerulonephritis and palpable purpura. It is strongly associated with MPONCA, also known as PANCA, which stands for antimyeloperoxidase antibodies. Treatment includes cyclophosphamide and glucocorticoids, offering effective control of disease progression. Finally, we come to eosinophilic granulomatosis with polyangiitis, formerly called Churg-Strauss syndrome. This condition is marked by a combination of asthma, eosinophilia, and systemic vasculitis. Eosinophilic infiltration leads to inflammation and frequently results in peripheral neuropathy. The underlying pathology shows granulomatous and necrotizing vasculitis with prominent eosinophilia. Laboratory tests typically reveal an elevated IgA level, which supports the diagnosis. Now let's talk about granulomatosis with polyangiitis, which affects males and females equally and typically presents in middle-aged adults. The disease is classically defined by a triad involving the lungs, vessels, and kidneys. Upper respiratory symptoms may include nasal septum perforation, chronic sinusitis, otitis media, and mastoiditis. Lower respiratory symptoms feature hemoptysis and dyspnea, while renal findings are consistent with pauciimmune rapidly progressive glomerulonephritis. The diagnostic marker for this condition is CNCA, also known as PR3-ANCA. Treatment includes glucocorticoids combined with either rituximab or cyclophosphamide, aiming to control systemic inflammation and prevent organ damage. Now listen carefully, because we're shifting to immune complex-mediated small vessel vasculitis, beginning with hypocomplementemich urticarial vasculitis, also referred to as anti-C1q vasculitis. This condition is often associated with systemic lupus erythematosus. It presents with urticaria, a purpuric rash, arthralgias, and may involve the gastrointestinal system, lungs, or eyes. Laboratory findings typically include reduced C1q complement levels and elevated anti-C1q antibodies. Recognizing these features early helps in identifying the underlying autoimmune disorder and guiding immunosuppressive treatment. Are you following me? Because next is mixed cryoglobulinemia, which is often due to viral infections, especially hepatitis C virus. This condition presents with a triad of palpable purpura, weakness, and arthralgias. It may also involve peripheral neuropathy and renal disease, such as glomerulonephritis. The disease mechanism involves cryoglobulins, which are immune complexes made of mixed IgG and IgM, and they precipitate in cold temperatures, leading to vessel inflammation and tissue damage. Now let's turn to immunoglobulin A vasculitis, the most common form of vasculitis in children, often following an upper respiratory infection. This condition involves vasculitis secondary to IgA immune complex deposition. The classic triad includes joint pain, referred to as hinge pain, abdominal pain, which may be associated with intussusception, and palpable purpura, most commonly on the buttocks and legs. Formerly known as Hanoch-Schönlein purpura, this disease is also associated with IgA nephropathy, also called Berger disease. Treatment typically involves supportive care, but glucocorticoids may be used in more severe cases. Now listen carefully as we wrap up small vessel vasculitis with cutaneous small vessel vasculitis. This form presents with palpable purpura and, importantly, does not involve visceral organs. It is an immune complex, mediated leukocytoclastic vasculitis. While initially confined to the skin, late involvement may indicate systemic disease. The condition often occurs 7 to 10 days after exposure to certain medications, including penicillins, cephalosporins, sulfonamides, phenytoin, or allopurinol, or after infections such as hepatitis C virus or HIV. Identifying the trigger is essential for effective management. Finally, let's talk about all-vessel vasculitis, beginning with Behçet syndrome, which shows increased incidence in individuals of Turkish or Eastern Mediterranean descent. This syndrome is characterized by recurrent oral and genital ulcers, uveitis, and erythema nodosum. The condition is often triggered by infections such as herpes simplex virus or parvovirus, and disease flares typically last between 1 to 4 weeks. Behçet syndrome is strongly associated with the HLA-B51 allele. Now let's talk about neuromuscular junction diseases, beginning with myasthenia gravis, which is the most common neuromuscular junction disorder. Its pathophysiology involves autoantibodies targeting the postsynaptic acetylcholine receptors, resulting in reduced availability of these receptors. Clinically, this condition presents with fatigable muscle weakness, including ptosis and diplopia, along with proximal muscle weakness, and respiratory muscle involvement, which leads to dyspnea. Bulbar muscle involvement may also occur, causing dysphagia and difficulty chewing. Reflexes are spared, and symptoms worsen with muscle use. This disease is commonly associated with thymoma or thymic hyperplasia. Administration of acetylcholinesterase inhibitors, such as pyridostigmine, reverses symptoms effectively. Antibodies to the ACH receptor are typically present. Are you following me? Because now we'll compare that with Lambert-Eaton myasthenic syndrome, which is far less common. Its pathophysiology involves autoantibodies against presynaptic calcium channels, which results in reduced acetylcholine release. An easy way to remember is that L comes before M, meaning the defect occurs earlier in the transmission process. Clinically, it causes proximal muscle weakness and autonomic symptoms such as dry mouth, constipation, and impotence. Unlike myasthenia gravis, this condition causes hyporeflexia and actually improves with muscle use. It's often associated with small cell lung cancer. Unlike in myasthenia gravis, administering acetylcholinesterase inhibitors has minimal effect. Now listen carefully, as we shift to Raynaud phenomenon, a condition marked by reduced blood flow to the skin due to arteriolar vasospasm in response to cold or stress. This causes a classic color change in the fingers and toes, beginning with white due to ischemia, followed by blue from hypoxia, and finally red from reperfusion. When this occurs without any underlying condition, it's termed Raynaud disease, or primary Raynaud. However, when it occurs secondary to diseases like mixed connective tissue disease, systemic lupus erythematosus, or CREST syndrome, which is a limited form of systemic sclerosis, it is known as Raynaud syndrome. In severe secondary cases, digital ulceration due to critical ischemia can occur. Treatment involves calcium channel blockers to reduce vasospasm and improve blood flow. Now let's talk about scleroderma, also called systemic sclerosis, which is defined by a triad of autoimmunity, non-inflammatory vasculopathy, and collagen deposition with fibrosis. The most common manifestation is sclerosis of the skin, producing puffy, taut skin that lacks wrinkles and may lead to fingertip pitting. But it doesn't stop there. It can also involve other systems, including the kidneys, causing scleroderma renal crisis, which is treated with ACE inhibitors, the lungs, where it leads to interstitial fibrosis or pulmonary hypertension, and the gastrointestinal tract, where reduced peristalsis and lower esophageal sphincter tone result in dysphagia and heartburn. Cardiovascular involvement is also possible. The condition affects women in 75% of cases and comes in two major forms. Now listen carefully, because the first type is called diffuse scleroderma, which features widespread skin involvement, rapid disease progression, and early visceral organ involvement. It is associated with anti-SCL70 antibodies, also known as anti-DNA topoisomerase I antibodies, and may also involve anti-RNA polymerase III antibodies. The second form is limited scleroderma, where skin involvement is confined to the fingers and face. This form often includes the CREST syndrome, which stands for calcinosis cutis, anticentromere antibody, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. Limited scleroderma usually follows a more benign clinical course compared to the diffuse type. Fellas, you are doing great if you reached to this. Now we reach dermatology subtopics. Let's start by talking about the structure of the skin, which is composed of three primary layers: the epidermis, the dermis, and the subcutaneous fat, also known as the hypodermis or subcutis. The epidermis, being the outermost layer, consists of several distinct strata arranged from the outermost to the innermost. To remember them, we say, "Come, let's get sunburned." These layers are the stratum corneum, the stratum lucidum, the stratum granulosum, the stratum spinosum, and finally, the stratum basale. Each of these plays a crucial role in maintaining the barrier, regenerative, and protective functions of the skin. Let's explore the different epithelial cell junctions, which are crucial for maintaining the structural integrity of tissues. At the apical end, we begin with tight junctions, also called zonula occludens, which prevent the paracellular movement of solutes. These are composed of proteins called claudins and occludens. Just beneath them, we find the adherens junctions, or belt desmosomes, referred to as zonula adherens. These form a belt-like connection linking the actin cytoskeletons of adjacent cells using cadherents, which are calcium-dependent adhesion molecules. You should remember that loss of E-cadherin facilitates cancer metastasis. Are you ready to go further? Because now we reach the desmosomes, also known as spot desmosomes or macula adherens. These provide robust structural support through interactions with intermediate filaments. In autoimmune diseases, antibodies targeting desmoglein 3, and sometimes desmoglein 1, lead to pemphigus vulgaris. Then come the gap junctions, which consist of channel proteins called connexins. These channels allow both electrical and chemical communication between cells, promoting coordinated cellular responses. Now let's talk about the base, because at the basal side, we find the hemidesmosomes. These connect keratin in basal epithelial cells to the underlying basement membrane. Autoantibodies targeting these structures cause bullous pemphigoid. A helpful way to remember is, hemidesmosomes are down, bulo. Below all of this, we encounter integrins, which are transmembrane proteins that secure the basolateral membrane by binding to collagen, laminin, and fibronectin in the extracellular matrix, ensuring stability and anchorage. Now listen carefully, because we'll finish with exocrine glands, which are different from endocrine glands. Exocrine glands release non-hormonal substances through ducts to the body's exterior. They function via three main types of secretion. Merocrine secretion, seen in salivary and sweat glands, involves exocytosis of secretory vesicles. Apocrine secretion, as seen in mammary glands, releases product through pinching off part of the cell membrane. Finally, holocrine secretion, which occurs in sebaceous glands, involves the entire cell disintegrating to release its contents. This completes the range of exocrine gland activity across the skin. Now let's talk about dermatologic macroscopic terms, beginning with macule, which is a flat lesion, showing a well-circumscribed change in skin color, and it measures less than 1 centimeter, and examples include a freckle, also known as a phyllis, and a labial macule. Then, we move on to patch, which is simply a macule that is larger than 1 centimeter, and a classic example of this is vitiligo, which presents as a larger area of skin color change without elevation. Are you following me? Now listen carefully. Papule is next, and it refers to an elevated, solid skin lesion that is smaller than 1 centimeter, and this type of lesion can be observed in conditions like neurofibroma or acne. Following that, we come to plaque, which is essentially a papule that is greater than 1 centimeter in diameter, and one of the most recognized examples of this is psoriasis, where the lesions are raised and scaly. Are you ready for the next? Let's continue with vesicle, which is a small, fluid-containing blister that measures less than 1 centimeter, and this type of lesion can be seen in chickenpox, also called varicella, or shingles, which is also known as herpes zoster. Then comes bulla, which is a large, fluid-containing blister, and it is greater than 1 centimeter, and an example of this would be bullous pemphigoid, where these large blisters appear on the skin. You should remember this. Next, let's examine pustule, which is a vesicle that contains pus instead of clear fluid, and this can be seen in conditions like pustular psoriasis, where the lesions appear raised and filled with purulent material. Then we have will, which describes a transient, smooth papule or plaque, often evanescent, and a typical example is hives, also called urticaria, which are itchy and often disappear within hours. Are you still with me? Now let's talk about scale, which is defined as the flaking off of the stratum corneum, or the outermost layer of the skin, and this feature is often observed in eczema, in psoriasis, or in squamous cell carcinoma. Moving on to crust, which is a dry exudate, it typically forms over lesions such as those in impetigo, where dried serum, blood, or pus is visible. Are you following closely? Next, we describe ulcer, which is the loss of the epidermis that leads to exposure of the basement membrane, and even the underlying structures such as the dermis, muscle, bone, or tendon, and this is seen in conditions like arterial ulcers, decubitus ulcers, and leprosy, where tissue breakdown extends deeper than the surface layers. Erosion, on the other hand, is a partial or full loss of the epidermis, but crucially, it does not expose the basement membrane, and examples include lesions seen in gastroesophageal reflux disease, also called GERD, or in erosive esophagitis. Now let's shift to microscopic terms. Now listen carefully, let's discuss dermatologic microscopic terms, beginning with dyskeratosis, which is defined as abnormal, premature keratinization of cells, and it can be seen in squamous cell carcinoma. Then we have hyperkeratosis, which refers to an increased thickness of the stratum corneum, and this finding is often present in psoriasis or in the thickened skin of calluses. Are you ready for more? Parakeratosis comes next, and it involves the retention of nuclei in the stratum corneum, which normally should not have nuclei, and this feature is commonly associated with psoriasis and actinic keratosis. Now let's consider hypergranulosis, which means an increased thickness of the stratum granulosum, and this change is characteristically found in lichen planus, a condition that shows thickened granular layers. Let's not forget spongiosis, which is the epidermal accumulation of edematous fluid in the intercellular spaces, and it's an important hallmark of eczematous dermatitis, where the skin appears puffy and inflamed. Are you following me? Next is acantholysis, which is the separation of epidermal cells from each other, and this process is famously seen in pemphigus vulgaris, where blisters form due to loss of intercellular connections. And finally, we arrive at acanthosis, which is epidermal hyperplasia, specifically referring to increased thickness of the stratum spinosum, and this histologic finding is associated with conditions like acanthosis nigricans and psoriasis. Now let's talk about pigmented skin disorders, starting with albinism, which presents with a normal number of melanocytes but reduced melanin production. This reduction is due to decreased tyrosinase activity or defective tyrosine transport, and it results in significantly increased risk of skin cancer because the skin lacks protective pigmentation. Next, we have melasma, also known as chloasma, which is an acquired hyperpigmentation disorder, and it is often associated with pregnancy, commonly called the mask of pregnancy, or with the use of oral contraceptive pills. This condition tends to be more common in individuals with darker skin tones, and it presents as symmetric, brownish facial patches, especially on the cheeks and forehead. Are you following me so far? Now listen carefully. Vitiligo is characterized by irregular patches of complete depigmentation, and it is caused by the destruction of melanocytes, which is believed to be autoimmune in nature. This condition is often associated with other autoimmune disorders. Now let's move forward. Waardenburg syndrome, on the other hand, features patchy depigmentation of the skin, hair, and irises, and it may be accompanied by sensorineural deafness. The underlying cause is a defect in the differentiation of neural crest cells into melanocytes, which not only affects pigmentation but can also interfere with inner ear development. Now let's talk about seborrheic dermatitis, which presents as erythematous, well-demarcated plaques with greasy yellow scales, and these lesions are typically found in areas rich in sebaceous glands, such as the scalp, face, and periocular region. In infants, it's commonly known as cradle cap, while in adults it can appear as persistent dandruff or facial dermatitis. Now listen carefully. This condition is common in both infants and adults, and in more extensive cases, it may be associated with underlying conditions such as HIV infection or Parkinson disease. Although sebaceous glands themselves are not inflamed, they do play a significant role in the development of this disorder, likely through the activity of Malassezia species. Are you still with me? Treatment usually involves the use of topical antifungal agents and glucocorticoids, which help control the overgrowth of Malassezia and reduce inflammation. Now let's talk about common skin disorders, beginning with acne, which has a multifactorial etiology involving increased sebum and androgen production, abnormal keratinocyte desquamation, colonization of the pilosebaceous unit by Cutibacterium acnes, and inflammation that leads to comedones, papules, pustules, nodules, and sometimes even cysts. The treatment approach includes topical retinoids, benzoyl peroxide, and antibiotics, targeting different aspects of the pathogenesis. Are you following so far? Next is atopic dermatitis, also known as eczema, which is a pruritic eruption associated with conditions like ichthyosis vulgaris and other atopic diseases, such as asthma, allergic rhinitis, and food allergies. This disorder is characterized by elevated serum IgA levels. It often begins on the face during infancy, and as patients grow older, it commonly shifts to the flexural surfaces in children and adults. Now listen carefully. Allergic contact dermatitis comes next, and it represents a type 4 hypersensitivity reaction, which occurs secondary to contact with allergens like nickel, poison ivy, or neomycin. This condition presents with itchy, erythematous lesions that appear at the site of contact, and its management involves identifying and avoiding the offending agent. You should remember this, especially when dealing with occupational skin complaints. Now let's talk about keratosis pilaris, which presents as follicular-based papules, resulting from keratin plugging of the hair follicles. It typically appears on the extensor surfaces of the arms and thighs. Melanocytic nevus, also called a common mole, is a benign proliferation of melanocytes, and although it is generally harmless, melanoma can arise in congenital or atypical moles. Intradermal nevi tend to be raised and papular, while junctional nevi are usually flat macules. Pseudofolliculitis barbae is an inflammatory reaction caused by hairs that penetrate the skin after shaving, leading to firm papules and pustules that are both painful and pruritic. This condition commonly occurs near the jawline and is more frequent in individuals with naturally curly hair. Often referred to as razor bumps, it can be managed by modifying shaving techniques and using topical treatments. Now listen closely. Psoriasis presents with papules and plaques that have silvery scaling, especially noticeable on the knees and elbows. It features acanthosis with perikeratotic scaling, where nuclei are retained in the stratum corneum, and it includes Monroe microabscesses. There is thickening of the stratum spinosum and thinning of the stratum granulosum. The Auspitz sign, pinpoint bleeding when scales are scraped off, is characteristic. This condition is also associated with nail pitting and psoriatic arthritis. Are you following me? Now let's explore rosacea, an inflammatory facial skin disorder characterized by erythematous papules and pustules, but notably, it lacks comedones. Flushing of the face in response to triggers like alcohol or heat is common, and complications may include ocular involvement and rhinophema, which is a bulbous deformation of the nose. Management includes trigger avoidance and appropriate dermatologic therapy. Seborrheic keratosis is a benign condition featuring well-demarcated, verrucous lesions, representing a proliferation of immature keratinocytes, and they often contain keratin-filled cysts known as horn cysts. These lesions appear to be stuck on the skin. The lesser Trelat sign refers to the sudden onset of multiple seborrheic keratoses, which may indicate an underlying malignancy, such as gastrointestinal adenocarcinoma. You should remember this red flag. Now let's talk about verrucae, or warts, which are caused by low-risk strains of human papillomavirus. They present as soft, tan-colored, cauliflower-like papules, and histologically, they show epidermal hyperplasia, hyperkeratosis, and cholocytosis. When located on the anus or genitals, they are referred to as condyloma acuminatum, and they are typically transmitted via skin-to-skin contact. Now listen carefully. Finally, we have urticaria, also known as hives, which are pruritic wheals that form as a result of mast cell degranulation. This reaction is characterized by superficial dermal edema and dilation of lymphatic channels. Let's begin with vascular tumors of the skin, and first, we have angiosarcoma, which is a rare blood vessel malignancy that typically affects the head, neck, and breast areas, usually in older adults, especially those with sun exposure. It is associated with prior radiation therapy and with chronic post-mastectomy lymphedema. A classic example is Stewart-Treves syndrome, where a cutaneous angiosarcoma develops after chronic lymphedema. Hepatic angiosarcoma, by contrast, is associated with exposures to vinyl chloride and arsenic. This tumor is very aggressive and difficult to resect, primarily due to delays in diagnosis. Are you following me? Now let's talk about bacillary angiomatosis, a benign condition that presents with capillary skin papules in patients with AIDS, and it is caused by Bartonella infections. This disorder is frequently mistaken for Kaposi sarcoma, but histologically, it shows a neutrophilic infiltrate rather than a lymphocytic one. You should remember this key distinction. Cherry angiomas are next, and these are benign capillary hemangiomas that commonly appear in middle-aged adults. Unlike some vascular lesions, cherry angiomas do not regress, and their frequency increases with age. They're typically harmless, but cosmetically noticeable. Let's move forward. A glomus tumor is a benign but painful, red-blue tumor that is commonly found under the fingernails. It arises from modified smooth muscle cells of the thermoregulatory glomus body, which is responsible for temperature regulation in the fingers. Though rare, it is important due to its distinct pain and location. Are you ready? Kaposi sarcoma is an endothelial malignancy that most commonly affects the skin, mouth, gastrointestinal tract, and respiratory tract. It is classically seen in older Eastern European males, in patients with AIDS, and in those who have undergone organ transplantation. This tumor is associated with HHV-8 and HIV, and it shows a lymphocytic infiltrate, which is an important feature that helps distinguish it from bacillary angiomatosis. Now listen carefully. Next is pyogenic granuloma, which is a polypoid, lobulated capillary hemangioma that may ulcerate and bleed. It is often associated with trauma and with pregnancy. Though it appears alarming, it is benign and treatable. You should remember this. Lastly, among vascular tumors, infantile hemangioma is a benign capillary hemangioma of infancy that appears within the first few weeks of life, occurring in roughly 1 out of every 200 births. It grows rapidly at first, but then it begins to involute starting at about age 1. Unlike cherry angiomas, infantile hemangiomas typically regress on their own. Are you following me? Now let's shift our focus to skin infections, starting with bacterial ones. Impetigo is a superficial skin infection involving the epidermis and is usually caused by Staphylococcus aureus or Streptococcus pyogenes. It is highly contagious and presents with honey-colored crusting. In the bullous form, blisters or bulli are seen, and it is typically caused by S. aureus. Now listen carefully. Erysipelas is another bacterial infection that involves the upper dermis and superficial lymphatics, usually caused by S. pyogenes. It presents with a well-defined, raised border that clearly demarcates infected from normal skin, a characteristic clinical clue. Let's keep going. Cellulitis is an acute, painful, and spreading infection that involves the deeper dermis and subcutaneous tissue, most often due to S. pyogenes or S. aureus. It frequently begins at the site of a break in the skin, such as trauma or a pre-existing wound or infection. Keep that in mind. Now let's talk about abscesses, which are collections of pus from a walled-off infection located in the deeper layers of the skin. The usual culprit is S. aureus, and they often require drainage as well as antibiotic therapy for full resolution. Are you ready to continue? Necrotizing fasciitis is a surgical emergency caused by deeper tissue injury, usually involving anaerobic bacteria or S. pyogenes. The pain can be disproportionately severe compared to exam findings, and it often results in crepitus from gas production, such as methane and carbon dioxide. Known as flesh-eating bacteria, this condition causes bully and skin necrosis with a violaceous discoloration of the surrounding skin. Now listen closely. Staphylococcal scalded skin syndrome is caused by an exotoxin that destroys the keratinocyte attachments in the stratum granulosum only, in contrast to toxic epidermal acrolysis, which affects the epidermal-dermal junction. There is no mucosal involvement, but patients present with fever, a generalized erythematous rash, and sloughing of the upper epidermal layers that heals completely. It is characterized by a positive Nikolsky sign, which is the separation of the epidermis upon gentle stroking of the skin. It commonly affects newborns, children, and adults with renal insufficiency. Now let's move to the viral infections. Herpes virus infections, including HSV-1 and HSV-2, can occur on mucosal surfaces and normal skin alike. They include herpes labialis, herpes genitalis, and herpetic whitlow, which affects the finger and is particularly painful. Now listen carefully. Molluscum contagiosum presents as umbilicated papules caused by a poxvirus. Although frequently seen in children, it may also be transmitted sexually in adults. These lesions are typically benign, self-limited, and may resolve without treatment. Varicella zoster virus causes both varicella, or chickenpox, and zoster, or shingles. Varicella presents with crops of lesions in various stages, from vesicles to crusts, while zoster is a reactivation of the latent virus and follows a dermatomal distribution, unless it becomes disseminated. Are you still with me? Lastly, we have hairy leukoplakia, which appears as irregular, white, painless plaques on the lateral tongue that cannot be scraped off. It is mediated by Epstein-Barr virus and occurs in individuals with HIV or those who have received organ transplants. It is important to distinguish this from oral thrush, which can be scraped off, and from leukoplakia, which is considered precancerous. Now let's explore the world of cutaneous mycoses, beginning with tinea, which is the clinical name for dermatophyte infections, also known as cutaneous fungal infections. The causative organisms include Microsporum, Trichophyton, and Epidermophyton, and under the microscope, they appear as branching, septate hyphae, which are visible on a potassium hydroxide, or KOH, preparation using a blue fungal stain. These infections are commonly associated with pruritus, making the skin itch and prompting medical attention. Tinea capitis occurs on the head and scalp, and it is frequently associated with lymphadenopathy, patchy alopecia, and areas of scaling. Moving on, tinea corporis affects the body, usually the torso, and is characterized by enlarging, erythematous, and scaly rings that show central clearing. This classic appearance gives rise to the common term ringworm. Interestingly, this infection can be acquired through contact with infected pets or farm animals, so zoonotic transmission should be considered. Now listen closely. Tinea cruris affects the inguinal area and is commonly referred to as jock itch. Unlike tinea corporis, it often lacks the central clearing and presents as a more solid erythematous rash. Tinea pedis, or athlete's foot, has three common forms: interdigital, which is the most frequent and appears between the toes, the moccasin distribution that involves the soles and sides of the feet, and the vesicular type, which is less common but still notable. Are you following me? Tinea unguium refers to onychomycosis, which is a fungal infection of the nails, and it can lead to nail thickening, discoloration, and deformity. While still under the umbrella of tinea, tinea versicolor, also known as pityriasis versicolor, is different, as it is caused not by a dermatophyte, but by Malassezia species, which are yeast-like fungi. These organisms degrade skin lipids, producing acids that inhibit tyrosinase, an enzyme involved in melanin synthesis, leading to hypopigmentation. However, you should also know that hyperpigmentation or pink patches can develop as a result of inflammation. This condition is less pruritic than dermatophyte infections and tends to be more common in hot and humid weather, especially during the summer months. Microscopically, tinea versicolor displays a characteristic spaghetti and meatballs appearance. Treatment typically includes selenium sulfide, as well as topical or oral antifungal medications, depending on severity and extent of the lesions. Now let's move forward and talk about autoimmune blistering skin disorders. Pemphigus vulgaris is a potentially fatal condition most commonly seen in older adults. It is a type 2 hypersensitivity reaction characterized by IgG antibodies that target desmoglein 3, and sometimes desmoglein 1, both of which are components of desmosomes, structures that connect keratinocytes in the stratum spinosum. The result is a loss of adhesion between cells, known as acantholysis, which leads to flaccid, intraepidermal bully. On H&E stain, this is described as a row of tombstones. Importantly, the oral mucosa is involved, and the Nikolsky sign is positive, meaning that gentle stroking of the skin causes the epidermis to slough off. In contrast, bullous pemphigoid is a less severe autoimmune blistering disease, also affecting older adults, and also a type 2 hypersensitivity reaction. But in this case, the IgG antibodies are directed against hemidesmosomes, which are located in the epidermal basement membrane. This distinction is often remembered by the phrase that antibodies in bullous pemphigoid are bulo, the epidermis. Clinically, the blisters are tense and contain eosinophils, and the oral mucosa is typically spared. The Nikolsky sign here is negative, which is another key difference to remember. Under immunofluorescence, pemphigus vulgaris shows a reticular pattern surrounding the epidermal cells, reflecting the intercellular deposition of IgG. Meanwhile, bullous pemphigoid displays a linear pattern along the epidermal-dermal junction, clearly delineating the separation caused by immune attack. Now listen carefully, we're about to go through other important blistering skin disorders, starting with dermatitis herpetiformis, which presents with pruritic papules, vesicles, and bully, and these are most often found on the elbows, knees, and buttocks. Under the microscope, there are deposits of IgA at the tips of the dermal papillae. This condition is strongly associated with celiac disease, and the treatment includes dapsone and adherence to a strict gluten-free diet, which helps resolve both skin and gastrointestinal symptoms. Now, are you following me? Erythema multiforme is another condition, and it is commonly associated with infections, such as Mycoplasma pneumoniae and herpes simplex virus, and also with drugs including sulfa drugs, beta-lactams, and phenytoin. Clinically, it presents with multiple types of lesions. These include macules, papules, vesicles, and especially target lesions. These target lesions look like concentric rings with a dusky central zone that indicates epithelial disruption. This polymorphic nature of lesions is a hallmark of the condition and helps distinguish it from others. Now let's continue with more severe forms. Stevens-Johnson syndrome is characterized by fever, bully formation, and necrosis, with sloughing of the skin at the dermal-epidermal junction, and it is marked by a positive Nikolsky sign. The mucous membranes are typically involved, which is an important clinical clue. Targetoid lesions, similar to those in erythema multiforme, may appear in Stevens-Johnson syndrome. It is usually associated with adverse drug reactions, and the condition can rapidly progress, leading to serious complications. When the body surface area involved exceeds 30%, we call it toxic epidermal acrolysis, or TEN. If the involvement ranges from 10 to 30%, the condition is termed SJS-10 overlap. Now let's talk about inherited forms. Epidermolysis bullosa refers to a group of inherited skin disorders that result in bully, erosions, and ulcers, often triggered by even minor trauma. These blisters typically present early in life, and oral blistering may occur during bottle feeding. The most common cause is mutations in keratin genes, which weaken the structural stability of the skin, making it fragile and prone to damage from friction or pressure. Now we shift to cutaneous ulcers, and will begin with venous ulcers, which result from chronic venous insufficiency and are the most common type of ulcer. These typically develop in the gaiter area, from the ankle to the mid-calf, and are usually found over the malleoli. They often have irregular borders, appear shallow, and tend to be exudative. Pain is usually mild to moderate. Associated signs include telangiectasias, varicose veins, edema, and stasis dermatitis, which manifests as erythematous, eczematous patches. Arterial ulcers, on the other hand, are caused by peripheral artery disease, such as atherosclerotic stenosis, and they tend to occur on the distal toes, anterior shin, or other pressure points. These ulcers are symmetric with well-defined, punched-out appearances. Pain is severe, and the surrounding skin often shows signs of arterial insufficiency, including being cold, pale, and atrophic, with hair loss and absent pulses. Now listen closely, because next we talk about neuropathic ulcers. Neuropathic ulcers, often seen in diabetic foot patients, occur due to peripheral neuropathy. These ulcers develop on bony prominences such as metatarsal heads and heels. They characteristically have hyperkeratotic edges with undermined borders, and pain is often absent due to the underlying nerve damage. Additional signs include claw toes, Charcot joints, and absent reflexes. These ulcers are frequently complicated by soft tissue infections and osteomyelitis, which further increases morbidity. Finally, pressure injuries, also known as pressure ulcers, result from prolonged, unrelieved pressure, especially in immobile individuals. These ulcers typically appear on weight-bearing points, such as the sacrum, ischium, and calcaneus. Their appearance varies depending on the stage, ranging from non-blanchable erythema to full-thickness skin loss. Pain is generally present, soft tissue infection and osteomyelitis are frequent. Prevention requires frequent repositioning and pressure relief strategies. Other miscellaneous skin conditions include acanthosis nigricans, a condition where there is epidermal hyperplasia that leads to symmetric, hyperpigmented thickening of the skin, most commonly found in the axilla or on the neck. This change is often associated with insulin resistance, including conditions such as diabetes, obesity, Cushing syndrome, and polycystic ovarian syndrome, and it may also be linked to internal malignancies like gastric adenocarcinoma. Moving to erythema nodosum, which presents as painful, raised, inflammatory lesions of the subcutaneous fat, known as panniculitis, and these typically appear on the anterior shins. While the cause is often idiopathic, it may be associated with a variety of conditions, including sarcoidosis, coccidioidomycosis, histoplasmosis, tuberculosis, and streptococcal infections, as well as leprosy and inflammatory bowel disease. Are you ready to continue? Let's go on to ichthyosis vulgaris, a disorder involving defective keratinocyte desquamation due to mutations in the filaggrin gene, resulting in widespread scaling of the skin. This scaling most commonly affects the extensor sides of the extremities and the trunk, and it typically begins in infancy or early childhood. There is a strong association with atopic dermatitis, and the skin often appears dry, rough, and fish-like, which is characteristic of the condition's name. Now let's move on to something pruritic and polygonal. Lichen planus is a distinctive skin condition remembered by the 6 Ps: pruritic, purple, polygonal, planar, papules, and plaques. Mucosal involvement presents as Wickham striae, which are reticular white lines, and the skin histology shows hypergranulosis. A sawtooth infiltrate of lymphocytes can be seen at the dermal-epidermal junction under the microscope. Importantly, this condition is associated with hepatitis C, so serologic testing is often warranted. Let's continue with a rash that shows up like a seasonal gift. Pityriasis rosea typically begins with a herald patch, which is a solitary scaly lesion that appears first and is followed, days later, by multiple other scaly, erythematous plaques. These plaques often appear in a Christmas tree distribution over the trunk, and they feature a characteristic collarette of scale at the edges. The eruption is self-resolving, typically clearing up in 6 to 8 weeks without the need for intervention. Now let's turn to sun-related skin injuries. Sunburn is an acute cutaneous inflammatory reaction resulting from excessive ultraviolet radiation exposure. It leads to DNA mutations that trigger apoptosis of keratinocytes, with UVB radiation being the dominant cause of sunburn, while UVA is more responsible for tanning and photoaging. Repeated or prolonged exposure to both UVA and UVB increases the risk of developing skin cancer, making protective measures essential. And finally, let's examine skin damage due to radiation. Radiation dermatitis may present as either an acute or late reaction. The acute form occurs within 90 days following radiotherapy and results from apoptosis of basal keratinocytes and epidermal edema, showing up clinically as erythema, desquamation, superficial ulceration, and sometimes blistering. The late form can occur months to years after exposure and is characterized by fibrosis, homogenization of dermal collagen fibers seen on histology, vascular injury, and the appearance of telangiectasias. Now listen carefully. When estimating body surface area affected by burns, we use the rule of nines. This method helps assess the total extent of burn injuries and guides fluid resuscitation and clinical management. Inhalation injury is a critical complication caused by the inhalation of noxious agents like smoke, heat, particulates less than 1 micrometer in diameter, or chemical irritants such as ammonia. These exposures can lead to chemical tracheobronchitis, airway edema, pneumonia, and acute respiratory distress syndrome. On physical examination, findings may include singed nasal hairs and soot deposition in the oropharynx. Bronchoscopy typically reveals severe edema, congestion of the bronchial mucosa, and soot accumulation, as shown in image A taken 18 hours after injury, with resolution demonstrated by image B taken 11 days later. Are you following me? Let's now walk through the rule of nines for surface area. The entire head represents 9%, the entire thorax 18%, each arm, left and right, 9% each, the entire abdomen 18%, the perineum contributes 1%, and each leg, left and right, accounts for 18% individually. This standardized method allows for a total of 100% body surface area, and these values are essential for proper classification and treatment planning in burn care. Now let's talk about burn classification, where we consider the depth of tissue involvement, appearance, and sensation. A superficial burn, which affects only the epidermis, resembles sunburn and appears as localized, dry, blanching redness without blistering, due to histamine release. It is painful. Moving deeper, a superficial partial thickness burn involves both the epidermis and papillary dermis, forming blisters that blanch with pressure, feeling swollen and warm, and are painful to temperature and air. A deep partial thickness burn extends into the reticular dermis, has fragile blisters that unroof easily, does not blanch with pressure, and is usually painless with perception limited to pressure. Next, a full thickness burn involves the entire epidermis and dermis. These burns appear white, waxy, dry, inelastic, and leathery. They do not blanch and are painless, with perception limited to deep pressure only. In deeper injury burns, even the underlying tissues like fascia and muscle are affected. These injuries look white and dry, with inelastic texture, and again, there is no blanching. Like full-thickness burns, they are painless, but the person might still feel deep pressure. Understanding these characteristics is key in determining burn severity and appropriate treatment. Now let's talk about skin cancer, starting with the role of sun exposure, which significantly increases the risk. Basal cell carcinoma is more common above the upper lip, while squamous cell carcinoma tends to occur below the lower lip. Basal cell carcinoma, or BCC, is the most common skin cancer and appears on sun-exposed areas like the face. It's locally invasive but rarely metastasizes. Clinically, it presents as waxy, pink, pearly nodules with telangiectasias, rolled borders, and central crusting or ulceration. Superficial BCC may also look like a scaling plaque, offering a different but related appearance. You should remember this: squamous cell carcinoma, or SCC, is the second most common skin cancer. It's associated with immunosuppression, chronic non-healing wounds, and in rare cases, arsenic exposure. A marginal ulcer refers to an SCC arising in chronic wounds or scars, typically developing more than 20 years after the initial insult. SCC often occurs on the face, lower lip, ears, and hands. These tumors are locally invasive, may spread to regional lymph nodes, but rarely metastasize. They present as ulcerative red lesions, and histology shows characteristic keratin pearls. We must also mention actinic keratosis, which is a premalignant lesion from sun exposure. These appear as small, rough, erythematous or brownish papules or plaques, and the risk of SCC rises with the degree of epithelial dysplasia. Now let's shift to melanoma, a common tumor with a high risk of metastasis. It is marked by the S100 tumor marker and often arises from dysplastic nevi, especially in lighter-skinned individuals. The depth of the tumor, measured by Breslow thickness, strongly correlates with metastatic risk. Clinicians rely on the ABCDES, asymmetry, border irregularity, color variation, diameter greater than 6 mm, and evolution over time. There are at least 4 types: superficial spreading, nodular, lentigo-maligna, and acro-lentiginous, with the latter most prevalent in people with darker skin tones. Most melanomas are driven by activating mutations in BRAF kinase. Primary treatment involves excision with wide margins, and advanced disease may be managed with immunotherapies like ipilimumab, or targeted therapies such as BRAF inhibitors, including vemurafenib. Musculoskeletal, skin, and connective tissue, pharmacology. Starting with, acetaminophen works by reversibly inhibiting cyclooxygenase, primarily within the central nervous system, and is inactivated peripherally. It is used clinically as an antipyretic and analgesic, but importantly, it is not anti-inflammatory. It is often chosen instead of aspirin, particularly in children with viral infections, to avoid the risk of Reye syndrome. However, you should remember this: overdose of acetaminophen leads to hepatic necrosis. This occurs because its metabolite, known as NAPK, depletes glutathione and creates toxic tissue byproducts in the liver. The antidote for this condition is N-acetylcysteine, which helps regenerate glutathione and reduce liver damage. Are you following me? Now let's talk about aspirin, which is a non-steroidal anti-inflammatory drug that irreversibly inhibits both COX-1 and COX-2 enzymes through covalent acetylation. This process inhibits the synthesis of thromboxane A2 and prostaglandins, prolonging bleeding time without affecting PT or PTT. The antiplatelet effect of aspirin lasts until new platelets are formed. Clinically, low doses, less than 300 mg per day, are used to reduce platelet aggregation. Intermediate doses, ranging from 300 to 2,400 mg per day, provide antipyretic and analgesic effects. Higher doses, between 2,400 and 4,000 mg daily, are necessary for anti-inflammatory action. You should remember this: aspirin has several adverse effects, including gastric ulceration, tinnitus involving cranial nerve 8, and allergic reactions that are especially common in people with asthma or nasal polyps. Chronic use may cause acute kidney injury, interstitial nephritis, and gastrointestinal bleeding. In children, aspirin can trigger Reye syndrome if used during viral illness. In toxic doses, aspirin first causes respiratory alkalosis, but over time this shifts to a mixed picture of metabolic acidosis and respiratory alkalosis. Treatment for overdose includes the administration of sodium bicarbonate to correct the acid-base disturbance. Now let's talk about celecoxib, which selectively and reversibly inhibits the COX-2 isoform. Remember this as celecoxib. COX-2 is found in inflammatory cells and vascular endothelium and plays a major role in mediating inflammation and pain. Celecoxib spares COX-1, which is responsible for maintaining the protective lining of the stomach. As a result, it does not cause the same corrosive gastrointestinal effects seen with other NSAIDs. It also spares platelet function because thromboxane A2 production depends on COX-1. Clinically, celecoxib is used in treating rheumatoid arthritis and osteoarthritis. However, it carries an increased risk of thrombosis and must be avoided in individuals with a sulfa allergy. Are you ready to continue? Let's review the broader group of nonsteroidal anti-inflammatory drugs, or NSAIDs, which includes medications like ibuprofen, naproxen, indomethacin, ketorolac, diclofenac, meloxicam, and piroxicam. These drugs work by reversibly inhibiting both COX-1 and COX-2, thereby blocking prostaglandin synthesis. Clinically, they are used as antipyretics, analgesics, and anti-inflammatory agents. Indomethacin has a special use, it helps close a patent ductus arteriosus. The adverse effects of NSAIDs include interstitial nephritis, gastric ulcers due to reduced prostaglandin protection, renal ischemia caused by constriction of the afferent arteriole, and even aplastic anemia in some cases. Now listen carefully, let's examine leflunomide, which works by reversibly inhibiting dihydroorotate dehydrogenase. This prevents the synthesis of pyrimidines and ultimately suppresses the proliferation of T cells. Leflunomide is used in the treatment of rheumatoid arthritis and psoriatic arthritis. However, it comes with several adverse effects, including diarrhea, hypertension, hepatotoxicity, and teratogenicity. These risks must be carefully considered before starting therapy. And finally, we arrive at bisphosphonates, including alendronate, ibandronate, risedronate, and zoledronate. These drugs are pyrophosphate analogues that bind to hydroxyapatite in bone, where they inhibit osteoclast activity and promote osteoclast apoptosis. Bisphosphonates are used in a variety of bone-related conditions, including osteoporosis, hypercalcemia, Paget disease of bone, metastatic bone disease, and osteogenesis imperfecta. But you should remember this: their adverse effects include esophagitis, osteonecrosis of the jaw, and atypical femoral stress fractures, all of which require patient monitoring and appropriate preventive measures. Have you heard about recombinant parathyroid hormone agents like teriparatide and abaloparatide are analogues of parathyroid hormone, and they work by increasing osteoblastic activity when given in a pulsatile fashion. These medications are used clinically for osteoporosis, and they lead to increased bone growth when compared to antiresorptive therapies like bisphosphonates. The adverse effects you need to be aware of include dizziness, tachycardia, transient hypercalcemia, and muscle spasms, which should be monitored during treatment. Are you ready for the next part? Let's talk about gout drugs, beginning with the chronic preventive treatments. Allopurinol is a competitive inhibitor of xanthine oxidase, blocking the conversion of hypoxanthine and xanthine into urate. It is also used in lymphoma and leukemia to prevent tumor lysis syndrome, associated urate nephropathy. Allopurinol increases concentrations of xanthine oxidase, active metabolites, azathioprine, and 6-mercaptopurine. You should remember this: painful flares of gout are preventable with proper use of these agents. The fucking febuxostat also inhibits xanthine oxidase. Think of it this way: febuxostat makes xanthine oxidase static. Another drug, pegloticase, is a recombinant uricase that catalyzes the conversion of uric acid to allantoin, which is more water-soluble and easier to eliminate. Then there's probenecid, which works by inhibiting the reabsorption of uric acid in the proximal convoluted tubule, and it also inhibits the secretion of penicillin. However, it can precipitate uric acid calculi and may cause sulfa allergy. The mechanisms of action involve purines like hypoxanthine being transformed via xanthine oxidase to xanthine, and then into plasma uric acid, while drugs like probenecid or high-dose salicylates affect tubular reabsorption and secretion. Now let's shift gears to acute gout drugs. NSAIDs are commonly used for acute attacks, but be cautious with salicylates, as they can decrease uric acid excretion, especially at low doses. Glucocorticoids can be given orally, intraarticularly, or parenterally for acute gout relief. And then there's colchicine, which binds and stabilizes tubulin to inhibit microtubule polymerization, impairing neutrophil chemotaxis and degranulation. Colchicine has both acute and prophylactic value, but it comes with adverse effects, including gastrointestinal symptoms, neuromyopathy, myelosuppression, and nephrotoxicity, all of which require vigilance during treatment. Let's dive into TNF-alpha inhibitors. Etanercept is a fusion protein acting as a decoy receptor for TNF-alpha fused to the Fc portion of IgG1, and it is produced using recombinant DNA technology. Remember this, etanercept intercepts TNF. Clinically, it is used for rheumatoid arthritis, psoriasis, and ankylosing spondylitis. However, it can increase susceptibility to infections, including the reactivation of latent tuberculosis, because TNF is crucial for granuloma formation and stabilization. Etanercept can also cause drug-induced lupus. Now let's talk about adalimumab and infliximab, which are monoclonal antibodies targeting TNF-alpha. These drugs are used in inflammatory bowel disease, rheumatoid arthritis, ankylosing spondylitis, and psoriasis. For biologic treatment specific to psoriasis, you should remember the drug targets. Ustekinumab targets IL-12 and IL-23, while ixekizumab and secukinumab target IL-17, and brodalumab targets the IL-17 receptor. Others like guselkumab, risankizumab, and tildrakizumab specifically target IL-23. And finally, let's not forget imiquimod, which binds toll-like receptor 7, TLR7, on macrophages, monocytes, and dendritic cells, thereby activating them and promoting a topical antitumor immune response. Clinically, imiquimod is used to treat anogenital warts and actinic keratosis. However, adverse effects include itching, burning pain at the site of application, and rashes, which are common with its use. Thanks for listening.